last 8 years. So they came in quite handy, and the staff was already tuned to the way of treatment of these patients. We've also been offering stereotactic radiosurgery and stereotactic body radiotherapy for brain, bone, lung, liver metastasis, and that was continued as such. We started doing the departmental sterilization at the end of the day with the UV disinfection lamps, which were fabricated locally by one of our friends. And for the smaller rooms, smaller size wattage, and for the bigger rooms, 250 watts UV lamps were used. Depending upon the size, the time was given, and it was implemented by the housekeeping under the guidance of our medical physics department. During COVID time, we asked permission from our fire, engineering, and security department, and were allowed to open the fire exit doors and allow the outside air ventilation through the corridors and the bunker rooms, keeping the air conditioning on to minimize the viral load if at all the patients have been, patients have entered and the staff has been exposed to the SARS-CoV-2. A unique difficulty faced by our department was the border restriction by different states and restriction with 14 days mandatory quarantine for the staff returning from containment zones. So there was 1 week actually, where we had only 3 technologists who could come in with 65 patients to be treated. And I'm grateful to my doctors and the medical physics staff who doubled up from their duties to take on the treatment for these patients. There were transport limitations because the public transport was not available to most of the patients, and there was the staff also. But over the time that has improved, and we started using telemedicine increasingly to cut down the face-to-face follow-up and minimize the non-essential travel for the patients and the families to the hospital. We also, as a hospital, devised new alternative ways for delivering medicines through volunteers, and patients could drive through pickup points, and also home collection from the lab services was implemented. The staff training and the postgraduate training programs, our meetings, everything was converted into virtual meetings, and we continued the training program, and 3 of our students have gone on to complete their exams also during the COVID time. To conclude, the COVID-19 pandemic has been a catastrophic event in the lifetime of the whole world. However, the war against COVID can be won, and we are already making great strides by learning from each other and working together. And our experience shows that it's possible and safe to provide good quality oncology services, especially for radiation oncology, with teamwork. The required prerequisite is a safe environment for both patients and staff. Although COVID has been a catastrophe, but the fringe benefit of COVID is that in Delhi, we are at least getting a cleaner air, a clear sky, and we are seeing the rejuvenation of nature. Thank you for your kind attention.
Thank you so much, Dr. Kataria, for this amazing, very well prepared, concise presentation. You really described what we were trying to do and during the COVID in our departments in a very nice way. Thank you so much, highly appreciated. I'll move the mic to Dr. Mohammed Shabana, the chairperson of Radiation Oncology Department in King Faisal Specialist Hospital and Research Center, for the second presentation.
Assalamu alaikum, good morning, and thank you for this nice, well-prepared conference. And our next speaker is Dr. Ganesh. He is the Chief Medical Physicist, Manipal Hospitals, Dhaka, and New Delhi, India. He is certified by the American Board of Radiology and as Associate Editor, Journal of Medical Physics. He will talk about how to manage unscheduled treatment interruptions in radiotherapy treatment course. Please go, Dr. Ganesh. Thank you.
Mute and start video. Share. Can you see my screen? Yeah, hello. Uh, okay, thank you very much, Chairperson, for giving me this opportunity. At the outset, I would like to thank all the organizers, especially Dr. Maha, and whom I worked in 2008 to 2009, for giving me this opportunity to be part of this academic event. I might be a little bit deviating away from the main theme, which is COVID-related effects on radiotherapy, but actually it is also related, my topic is also related to the COVID, because there may be many unscheduled treatment interruptions occurring during the part of the radiotherapy treatment course, especially due to COVID. So we often come across unscheduled treatment gaps occurring in a typical radiotherapy treatment course due to various reasons, personal reasons, patient reactions, and that includes COVID-related treatment gaps also. And these gaps can occur either early or late during a treatment course, and the durations of the treatment interruptions can also vary in a very large way. The question is that how can we mitigate the effect of such unscheduled treatment interruptions? The traditional approach is always we looked at how many more fractions to account for an unscheduled treatment gap. That's how we always approached this treatment gaps problem. And what we do is that normally we look at we take the help of the TDF tables and see that how many more fractions that we have to give to the patient to account for the unscheduled treatment gap. That's how we always did. And these TDF tables were published way back in 1973, almost 50 years ago. However, the Royal College of Radiology approach is completely different from that of the TDF, and it is conceptually different and fundamentally different. And no more we talk about increasing the number of fractions. That is not the solution proposed in the Royal College of Radiology. Instead, the focus is on the overall treatment time and how to complete the planned treatment within the planned overall treatment time, or with minimal extension to this OTT, overall treatment time. That is the main focus. And that's what we have to keep our focus on in case of treatment gaps like occurring due to the COVID. The basis behind this RCR document is that any prolongation of the overall treatment time is going to increase the risk of the local recurrence. Even the day gap is going to result in 1.4% reduction in local control. And this happens due to the rapid cellular repopulation of the tumor cells. And this rapid cellular repopulation usually starts approximately 28 days after the start of the course, but that can vary from tumor type to tumor type. And most affected tumor types are the ones, obviously, that are fast proliferating, like all the squamous cell carcinomas, cancers of the esophagus, and also medulloblastomas and peanut tumors. So these are the tumors that are going to be mostly affected by any unscheduled treatment interruptions in the part of the treatment course. Now, RCR takes the help of these two equations about which almost all of us are familiar. The first one is for the normal tissue, where n is the number of fractions, d is the dose per fraction, and alpha beta is usually taken as the free gray for normal tissue. And for this equation is for the tumor BED. And here the overall treatment time and T delay, that is the time elapsed from the beginning of the treatment to the onset of the rapid repopulation, all these things come into picture. And alpha beta, as we know, that it is usually taken as 10 gray. Now, K can again vary from tumor type to tumor type. But what we have to note down here is that in normal tissues, the overall treatment time doesn't play any role in this equation. If when we look at it, overall treatment time doesn't come into play. But however, in tumor BED, the overall treatment time plays a role. And as the number of treatment days prolong, this is going to affect the tumor BED. So the methods that have been proposed in the RCR guidelines is that first we need to try every possible way to complete the course without exceeding the planned overall treatment time. No change in daily dose, no change in the number of fractions. If that is not possible, then we have to try other options like hyperfractionating the treatment or altered the fraction sizes or treating the patient twice daily. And then look at these options and choose the best option that will result in the minimum extension to the treatment time. Keep always focus on the overall treatment time. However, when we do this, when we do either of this, we have to compromise one. Either you keep the normal tissue BED unchanged, compromising the tumor BED, or vice versa. Tumor BED unchanged, compromise on the normal tissue BED. Or we can just take a balanced approach, compromising on both little bit in order that we do not take too much risk on either side. So I'm going to show you 4 examples. In example 1, for a treatment course running into 7 weeks, the patient doesn't come for the 3rd week. After getting treatment for 2 weeks, the patient doesn't come for 3rd week. Now what to do, how to take care of this gap? So either what we can do is that 20 fractions and treat remaining 20 fractions, and also 5 of the remaining 6 weekend days. Make use of the weekend days to deliver these 5 fractions, or treat twice on 5 of the remaining 20 treatment days. Friday are a good choice. Actually, I made this presentation for Indian scenario. There in Saudi, the weekend will be different. So Friday, so instead of Fridays, you have to read this as Thursdays are good choice. I will pictorially more clearer. These small circles, filled circles, is the normal treatment delivered, and these 2 squares, Saturday, Sunday, here in India, weekends. So ideally, the patient should have been treated in these 7 weeks time. But what happens after getting 2 weeks of treatment, patient doesn't come for the entire 3rd week, hollow circle, empty circle. So that means that the fractions patient did not receive. So what to do? We can do one thing: treat on this weekend 2 extra fractions, once here during this weekend, and then twice again during this weekend. So 5 fractions, missing 5 fractions accommodated here. Or we can do one thing: if you are not able to treat on the weekends, then treat twice on these Fridays. You have to read it as your weekends, actually, the day before the weekend, and then treat twice on Tuesdays and Fridays. So what did we achieve by doing this? We did not extend the overall treatment time. You see here, the overall treatment time remains the same in these 2 options also. That is the focus, as I told in the initial slide. Now, example 2, same patient doesn't come for 1 week, but then instead of the 3rd week, the patient doesn't come for the 6th week. So treat twice daily on each weekday of the final week, or if possible, use the weekend. Let us take the help of the pictorial representation. That's what actually the patient should have received. Patient doesn't come for the 6th week after getting treatment for 5 weeks. And what you have to do is that either treat twice for the remaining treatment days, or make use of the weekends also, and also twice daily on 3 of the days. So that way, you will be able to complete the treatment course within the planned overall treatment time. So there is no need for looking at those 2 equations. Without taking the help of those 2 equations, we can complete the overall, we can complete the treatment within the planned overall treatment time. Now, 3rd example, patient doesn't come for the 7th week. Then what options do we have? As I told you in the beginning, either you keep the normal tissue BED unchanged, like this, that's why I have put it on green, and compromise on the tumor BED, means red. So you have to accept a lower BED. So BED for tumor will go down in the red color. You see here. See here, now the patient doesn't come for the 7th week. There is no way that we will be able to complete the treatment within the planned overall treatment time. We have to go for extension of the treatment time. So either we give the remaining fractions like this without bothering anything, and that way what we'll have 7 extra days, means the overall treatment time is extended by 7 days, and that will result in a reduced BED 61.5 or 9.3% reduction. Instead, we can do one thing, we can take help of we can deliver treatment in this weekend also, so that overall treatment time is not now anymore 7 extra days, but only 5 extra days. So when we reduce 7 extra days to 5 extra days, instead of 9.3, the tumor BED falls only by 6.6%, or in other words, it is equivalent to delivering the tumor a dose of 65.4 gray. We can do one thing, we can further reduce the overall treatment time to only 3 extra days, and that way the reduction in tumor BED will be limited only to 4%. So that is example 3. Now, if the doctor says that, no, I don't want the tumor BED to be compromised, I have to keep it same as initially planned, but let us compromise on the normal tissue BED. In that case, normal tissue BED will go up in red color. That's what I have shown in red color. So now, what does it relate to? Actually, the 7th week patient doesn't come. So we have to increase the dose per fraction. If we increase the dose per fraction, only 5 extra days, the tumor BED is kept same, but look at the dose per fraction, it will come to 2.62. Where did this 2.62 gray come from? When we use that equation, we will be able to get this value. And still but the normal tissue BED goes up 6.7%, or it is equivalent to delivering a dose of 74.7 gray. Or we can do one thing, we can treat on the weekends also. So thereby we are increasing the dose per fraction, but also reducing the overall treatment time. And in that way, uh, 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 what we are doing is that instead of 2.62 gray, we can deliver at 2.3 gray. So this is a balanced way of doing it. So we are compromising little bit on tumor BED, we are compromising little bit on the normal tissue BED, and then we are delivering a dose per fraction 2.3 gray instead of the 2.62 gray if you are feeling not comfortable with the value of 2.62 gray. Now, 4th is even more complicated. The patient doesn't come not only for the 7th week, but also 6th week. So 6th and 7th week, patient doesn't come. So one way is to deliver of the patient after the patient returns back after the gap, whether it is for personal or COVID related gap. You just treat for 8th and 9th week, and that way tumor BED from planned 67 point, it will dramatically drop down to 55.2. You will have to accept if you are going by this option. Or you can do one thing, you can treat on Monday to, all these weekdays by a large dose per fraction, that is 3.22 gray for the remaining 5 fractions. Just deliver these 10 missed fractions with the only 5 fractions, so that overall treatment time is not extended by many days, just only 5 fractions, 3.22 gray. But even then the tumor BED is 13.2% less. Or you can deliver, instead of 5 fractions, you can deliver in 7 fractions. The dose per fraction is now only 2.6 gray into 7 fractions. Or you can deliver in 11 fractions like this, treating twice daily on some of the days. And there you have to give only 1.87 gray into 11 fractions. So this way you will be able to keep the normal tissue BED intact, but compromising little bit on the tumor BED. Or if you want to keep the tumor BED unchanged and compromise on the normal tissue, then in that case, what you have to do is that for the remaining 10 fractions, you have to give a dose of 2.85 gray. So all these options are available by taking the help of those 2 equations. Now, these 2 equations are fine, but then there are gray areas. Head and neck case examples that we have seen, they are okay. But then what about other tumors for which we may not be knowing alpha by beta values for sure? And also values of K have been proposed as 0.1 for slow growing, 0.3 for average growing, and 0.6 for rapidly growing tumors from Colin Orton's own words. He has not used 0.9 like the RCR has used. And the T delay We had seen in the equation we used 28 days, but then if you look into the literature or some of the published works, we can see that it can vary from 28 to 34 days depending on the tumor types. There are ready-made softwares are also available, which you can purchase for a couple of some $10, something like that. And we made in our department our own Excel sheet, which we took the help at the time of this COVID pandemic. And we developed our own application, which you can download from this link. And or if you want, you can write to me on my email. One thing, many times people ask that how to manage gaps of 3 months or 5 fractions. Say like the patient got treatment for 2 weeks and then 3 months break COVID. Now patient has come back for remaining 5 weeks of treatment. Now how to account? These equations are not any magic potion. So we are just talking about managing the gaps, not for managing the gorges. 15 fractions short course after 5 fractions patient doesn't come for 45 days. These things cannot be accounted using the RCR approach. It's only meant for short gaps, not for long gaps. To summarize, try to prevent the by counseling with the patients, and the interruptions occur, make efforts to keep them short as much as possible. As short as possible. Complete the treatment course within the planned overall treatment time. And if it is not possible, try other options like changing the dose or number of fractions. Focus should be always on minimal extension to the overall treatment time. And only short treatment interruptions can be addressed using the RCR approach. There is no magic solution for long interruptions. And every department must have an audit system in its place to monitor any gaps occurring. Thank you for your attention. And
thank you very much. Thank you, Marich, very much for this very nice, well summarized talk for a difficult topic. I think I give my colleague to introduce a third speaker.
Yes, it's my pleasure today to present our third speaker. Mr. Wadhawan is a chief radiation therapist technologist, and he is the chairman of the Association of Radiation Technology of India, the president of the Joint Forum of Medical Technologists of India. He's also an expert in the International Atomic Agency for a project of radiation therapy in India. He's a member of different international society like the ISTRO and ASTRO. He will present his presentation today through videotaping, but he will be with us in regarding to any question or clarification during the discussion. So I ask the team if we can have the lecture of Mr. Wadhawan.
Good morning, dear all. Myself, Gurvinder Singh Wadhawan, Chief RTT from Rajiv Gandhi Cancer Institute and Research Center, Delhi, India. Would like to share my experience on COVID outbreak radiation therapist part. As we all know that COVID has affected whole world, medically and financially. We need to understand, to control it, to win the results. So we have to understand how close to close is sufficient, how patient setting, how patient matching with all coordinates precisely and safely should be taken care during this pandemic outbreak. So let us first understand what exactly is this pandemic. It is a SARS coronavirus 2 also known as severe acute respiratory syndrome coronavirus 2, highly infectious disease, mainly transmitted through droplets generated when an affected person coughs, sneezes, or exhales. These droplets fall on floors or surfaces and infected by breathing if within close proximity of someone who has COVID-19 or by touching a contaminated surface and then touching eyes, nose or mouth. So the result going to be the mild illness that can make some people very ill, and the disease can be fatal for older and with pre-existing medical conditions such as blood pressure, heart problem, or diabetic patients. Therefore, situation need to take a calculated risk to manage smoothly in the interest of safety of patient, attendants, visitors, and staff with alertness all the time. I am thankful to organizing committee as well scientific committee and especially thanks to Professor Maha Idrisi and Mr. Gayur Ali along with Brian for giving this platform webinar. Webinar platform is helpful for the community with insights of radiotherapy developments in which a, a movement of professionals is avoided. So we can update ourselves sitting in our offices, sitting at homes, in our rooms, but we are always getting updates with our professional inputs. So focusing on ways to ensure efficiency and better management. How source of infection we are going to get from these. Let us know whether getting infection from home and community, getting infection from COVID-19 positive patients, getting infection from each other, that has to be taken care. So attention has to be taken. RTDs are frontline staff on machines must strictly follow appropriate face mask, face shield, gloves, caps, and hand hygiene because the disease spread through asymptomatic patients before they are identified and their median incubation time is 4 to 7 days. So the alertness has to be there, attention has to be there. Patients are in high risk for mucus exposure, such as those with laryngeal tubes. Weak immunity of cancer patients due to use of chemotherapy, radiation therapy, or surgery is a matter of attention. Staff exposure, their workflow, groups stop working in groups, and the backup staff planning has a matter of attention. Exchange of daily appointment slip cards on machine. If the machine or unit is down, then avoid cross contamination. Patient staggering has to be done, and engineers to perform repair has to be given the way. So gathering of patient in the RT waiting area may further increase the risk of infection. Masks compulsory for all patients and their accompanying caregivers first go through a temperature checkup point at the outpatient gateway. If fever detected, then refer to a specialized clinic. Now, how much this is true in our day-to-day work practice? Sometimes we are careful, sometimes we are not. While interacting among each other, relaxed, mask not worn properly, social distancing not maintained, and group chatting is also being done, food together in clusters. So it means first we have to adapt ourselves to live without getting infected and without infecting others. Now, when we come uniquely to radiotherapy practice, so radiotherapy works by making small breaks in the DNA inside cells. These breaks keep cancer cells from growing and dividing and cause them to die while using high energy radiation. The goal of our radiation therapy treatment, giving optimal dose delivery with minimum acute and long-term side effects and toxicity which affects the patient's survival. So challenges during this radiation therapy and during this situation currently what we are facing has to be taken care because we are very close proximity of tumor and critical structures. And in that case, precise treatment planning and delivery has to be taken care. Total dose delivery limited by tolerance of normal structures has to be taken care. Dosimetric challenges due to the setup uncertainties has to be taken care. And when the patient condition comes, then there is also compromised tolerance to treatment, poor nutritional status and weight loss, inadequate oral intake of the patient is going to affect during treatment. So the conformal radiation therapy needs an special care while we we are facing this pandemic situation. Before implementation of plan, before high dose delivery fraction need to make the setup coordinates as per the plan coordinates. Needs to be verified the shifts in X, Y, and Z directions within tolerance limit. So the close work practice is you cannot avoid. So in that case, the attention while doing this exercise during the planning of simulation, during the delivery of treatment has to be taken care. So challenges are going to be in that case a multi-fraction course of treatment which cannot be postponed. Each week of delay translates to 14% lesser cancer control. This is published data available. So another challenge that radiation therapy side effects are mimicking COVID-19 symptoms like low-grade fever, cough, sore throat, maybe due to the that comes maybe due to the mucositis in head and neck, and when we are treating lung cancer patient, then respiratory symptoms of varying degree that are going to give a challenge for our patients, radiotherapy patients. Then the manpower planning to keep them safe from the disease and to prevent burnout. RTT need to make sure all immobilization devices in use includes masks and hardware can be cleaned and disinfected with Acrocept disinfectant, which is recommended by WHO with a soft cloth after use to avoid contamination. And this is helping in cleaning the pre-cuts on regular basis, which remove the layer of dead bacteria that may have formed on the positioning devices in day-to-day practice. So the team responsible for organizing and managing radiotherapy patients will educate COVID-19 protection and prevention policy prior to the first treatment to the patients. Each patient's comfort level of wearing a mask was carefully balanced against the immobilization accuracy. Off-site therapists would support emergency and will be rotated weekly without overlapping with group A and B. So if any ITT develops symptoms or suspected, then mandated to notify the specialist and stop reporting to work, and other staff members in close contact with this professional were required to be quarantined immediately and would not return to work until an infection was ruled out. Appointment and machine slot should also be taken care of with social distancing. Avoid overcrowding by reducing number of patients per hour per slot in order to accommodate the disinfectant procedure. Waiting area designed in such a manner to allow adequate gap between two patients. Labels were added to identify designated sitting areas. Even floor stickers allowing limited number of patients. Similarly, in treatment control room, RTTs and staff wearing PPE kit maintain distance. So, what are the recommendations we should share to minimize this infection? That lunch break staggered, sitting 6 feet between two persons or 4 persons sit in 4 corners of the room if possible during taking the any eatable items. Discourage sharing of lunch from common tiffin, sitting arrangement with vaccine chairs because surface can be easily disinfected. Entry exit doors, reduce touching of handles and knobs. Washrooms, extra caution while opening and closing taps to prevent contamination. Soap up the tap knob in beginning and after washing hands, clean tap knob and close. Long chains, finger rings, leather belt, purse, and other accessories which we cannot wash out at the end of the day must be avoided. Hair tie up while in hospital and wear a cap all the time. Care of mask, goggles, and face shield should be taken care when you are using. How? Not to touch the inner surface with bare hands. Sanitize face shields and goggles before and after use and store them in a proper place. Do not leave lying here and there. Label them with your name. Carefully wear and remove a mask by holding the straps without touching the surface of the mask. If you are using the lift, better avoid using lift to the extent possible and use stairs. Otherwise, in case if you are using the lift, make sure it is not too crowded or wait otherwise. All the people standing in a lift should be facing the wall and as far as possible to avoid each other breaths. Use a tissue paper, pen, gloved finger to press the lift button. If using stairs, do not hold the railing of the staircase. When you use mobile, then regular sanitization several times a day or keep in a sealed transparent plastic pouch, preferably to use speaker to avoid close contact with the mouthpiece, which may be possibly contaminated. So this is what the social distancing at our institute is being maintained. For temperature checkup, even the queue which is arranged at the gate of machine area has to be given with distancing pattern in that way. And the sitting in the waiting hall with adequate gap is maintained to avoid overcrowding and any kind of reception in that. So patients considered high risk for mucus exposure, such as those with laryngeal tubes, were treated at the very end of the day to avoid any risk for the day. And if possible, a surgical mask may be used to cover the laryngeal tube during treatment. And during simulation also, during planning also, if possible, patient is comfortable, the mask should be preferred. Discourage the placement of immobilizing devices, the distancing and the placement pattern should be organized properly to avoid any kind of contamination among these devices also, and encourage a practice for keeping a gap between all of them. These current positioning and immobilization devices needs proper sanitization before use to radiotherapy patients, so that so in that case the care has to be taken that immobilization devices were disinfected by wiping disinfectant solution, and the care also be taken when RTT or other staff, if involved for treating the corona patients undergoing radiotherapy, the procedure to wear the PPE kit, because if if we are not following a proper procedure for wearing the kit, there is a risk for them damaging the kit, and we will be prone for any kind of infection. Then there should be a routine sanitization in the department, maybe depending on the protocols designed twice a day or thrice a day can be arranged. So sometimes we in current situation we face few of our RTTs got infected. Then we, while returning on job, we encourage them with a welcoming inputs. So I will show you this video little later on. So what kind of standards of operating the department should be followed during this pandemic outbreak has to be taken in practice, like no unwanted items should be stored in the area. Do not entertain any person if not covering face with mask or clean clothes. Patient screening while coming for radiotherapy treatment limited to one accompanied person only. Staff screening while entering to work should also be done the radiation treatment room and nearby areas should be thoroughly disinfected during treatment intervals. And RTTs have very regular close contact with a large number of patients every day. So there is a need to be careful while performing precise sets on planning and treatment units with proper staff schedule. And when we are using equipment area, highly specialized area, which will usually treat high volume of patients every day, contain large area of potential contamination, need special care. So the environment, physical separation, mixing of a number of patient groups in waiting area between patients on active treatment and those in follow-up should be organized carefully. So thank you very much. Stay safely, work safely, and meet safely. So the conclusion is the accuracy of each step has a major impact on both tumor control and normal tissue complications. So this requires an exceptionally high degree of accuracy in the treatment delivery system, which is in the hands of RTT, how they are going to manage in on equipment area where day-to-day practice has to be followed. So I will just do the try to open the video for a second, which we use to prepare when the RTTs return after infection on work practice. So these few RTDs, they were infected during their work, and then when they joined back, we welcome them as a Corona warriors. This is just like as an encouragement to the staff and that we do. So thank you very much for giving me opportunity to share our experience. Thanks.
It's excellent presentation, Mr. Woodhowen, and we're running a bit late in our schedule. Dr. Ahlam will take any question because we're a bit late, and then maybe we can move for the second session. But I will leave the questions with Dr. Ahlam now. And I apologize, I did not introduce Dr. Ahlam. She's the chairman of Radiation Oncology Department at King Fahd Specialist Hospital in Dammam, and she's one of the leaders in our field as a radiation oncology female. And it was a great pleasure to work with Dr. Ahlam through all these years of experience. And we also have Dr. Mohammed Shabana. He's our senior lead consultant and head of the department of King Faisal Specialist Hospital in Riyadh. And if Dr. Ahlam can lead the question, I will leave the floor now for Dr. Ahlam.
Thank you so much, Dr. Maha, for your nice words. It's a pleasure to be with you. It's our honor. Okay, let's see if we have any questions. I'll open the chat. If you have any questions, can you please type it in the question and answers box?
Well, I have a question for Mr. Wadhawan. I see that they had great experience dealing with the patients and also with the staff who's been surviving the COVID. I see also they had took the strategy of 2 groups and switching every week. And I was just wondering, from what we hear and see from the media in India, from their his personal experience, was there is so many staff infected by his experience in the radiation unit. If he can hear me, I wish if he...
Thank you, Doctor. Very, very good question you have asked. We have around 30 RTTs, 30 therapists in our department, and I feel proud to say that only during whole this 2.5 year pandemic, we got only 4 RTTs infected with COVID-19, because the pattern of safety, the protocols has been very nicely followed by RTTs on machines. So everyone was very well in safe position. So this is what the only figure, only 4 RTTs got infections, and they were also not very acute, only mild infection. Thank you very much.
I will also ask Dr. Kataria, vaccine in India, and from her experience, and that the vaccine was introduced later on. Was there is any mandate about the vaccine of the staff and also the vaccine for the patients, or how the team manage in your center?
Thank you for the question, Dr. Alderisi. The vaccination drive was started with our hospital in India, and we were the first ones to get the doctors, and the healthcare workers were offered the vaccine in the month of January and then February. And it was, with great trepidation that the staff agreed. Not everybody was forthcoming, and they had misconceptions regarding the side effects of the vaccination and a lot of, fear about the side effects of the vaccine. So after about 2 months, the hospital decided that all the staff members have to be encouraged, and repeated reminders were sent. And we had to talk to our team members that the risk of getting COVID vaccination is worse than getting the vaccine. So by now, I think by the month of April, we were able to vaccinate most of the staff members except the new joinees. Regarding the patients, there is no kind of a mandate that they have to be vaccinated, but it's being encouraged. And we are continuing to do RT-PCR for our patients on treatment before and every 15 days during treatment. Although for the last 2 months, we've been fortunate not to have patients who've tested positive for COVID, and the hospital also is not having the full services. Maybe 1 or 2 patients of the whole hospital are, admitted only with COVID. So we've closed all the floors, and normal routine work has been now implemented. But the countrywide, there is almost 25% of the population has been given a vaccination, and 2 vaccines have been delivered. There is a mix of vaccines which is available. There was shortage in between, as you all know, and now we are on the track, and it's a very rapid course of vaccination which is going on throughout the country.
Excellent. Maybe Dr. Ahlam can move to the second session because we are running a bit late, not that much, but I think our next team from Europe are waiting. So Dr. Ahlam, can you kindly introduce the second session?
Sure. I would like to thank everyone who participated in this first session, Dr. Kitara, Dr. Ganesh, and Mr. Wadhan, for very nice and good presentation. And our next presentation will be by Dr. Majid Al-Uthman. Dr. Majid Al-Uthman is a very well-known radiation oncologist and the chairman of radiation oncology at Johns Hopkins Aramco Hospital. And Dr. Uthman will start his session presenting to us. Just let me find the subject. I can't find it. So Dr. Majid, can you please start your session?
Thank you so much, Dr. Ahlam, and thank you, Dr. Al-Idrisi, for this kind invitation. I would like to thank the organizers and the speakers and the audience for joining us today in sharing experiences in this pandemic. So from the east, we go west to France and Italy, and we have Dr. Stefan Supio from France and Dr. Valentina Pinzi from Italy, as well as our Saudi delegate in France, Dr. Hawaj Al-Mukhlis, who is a Saudi who is working in France. With me, our co-moderators, I'm in the East Coast of Saudi Arabia, and Dr. Mohammed Al-Maghrabi in King Abdullah Medical City in the West Coast, and in the central area in the capital, we have Dr. Ali Balbaid in King Fahd Medical City. So we will start first with Dr. Balbaid.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Dr. Majid, for this nice introduction. And we would like to open our second session by Professor Stefan Supio. He's a pediatric radiation oncologist at UniCancer, University of Nantes, France. He's a senior radiation oncologist. His interests are in the development of therapeutics for prostate cancer radiotherapy. He has worked extensively in the area of hypoxic response modifiers in prostate cancer models. He is principal investigator on several clinical studies and has been involved in the study of novel therapeutics in prostate cancer radiotherapy. He's also the awardee of the ASCO Merit Award in 2007 and the prestigious Eastro Varian Juliana Dinikamp Award in 2009. So with no further ado, would like to welcome Professor Supio to talk about COVID-19 outbreak and radiation oncology services, lesson learned from France in the pediatric cases. Thank you, Professor Supio. You're most welcome. You can start your presentation.
Thank you very much for this nice introduction. I will give you insights from the French side, and I will try to focus mostly on pediatric cases, but not only on that. So what we learned from France and what really happened, because it was a very tough time, and now I have to say that it's almost over. So of course we can probably talk about what is the feeling now. So during the first wave in March 2020, I have to say that the first sensation, the first feeling was anxiety. As you could see that the COVID outbreak from China, they moved to the US and Italy and Spain. And in France, we were anxiously waiting for the COVID to strike. And we were very anxious about that. Basically, it started in the eastern part of France and then moved west, and Paris was struck. And my colleagues in Paris just say that it was a catastrophe. So we had to deal with an emergency response. And this was, of course, done in a very short period of time, only a few days. And this is what my colleagues at Institut Curie in Paris just published recently. This is in French, but it can be, of course, easily translated to anything that can be related to any department. Basically, what was done in these very first days was moving staff from research to treatment. This is something obvious, but many researchers had to change their profession to getting back to practice. moving staff from one department to COVID dedicated department was also important because the wave was too high to deal with COVID patients and COVID patients with cancer, of course. We also saw a very important movement from staff moving from uninfected region or mildly infected regions of France to pandemic regions. And that was a very important moment of solidarity between the regions in France, with thousands of nurses and physicians moving to the eastern part of France and Paris to try to provide the best care as possible. We also used and employed medical students for patient screening, for example, or for helping staff when staff was missing. Similarly, medical students, nurse students, and RTT students were highly used to replace affected staff or to help when the situation was too difficult to deal with. We had to also share our polymerized chain reaction equipment, which was mostly used for research, and we had to send them for hospitals or use them for the SARS-CoV-2 detection, which was something, of course, completely changing. And this was especially important for research departments. And what was a very striking effect of the COVID infection in the very, very first days was that we definitely assisted to a very intense bibliography and research effort. Almost every hour, we would have news from the COVID infection and how it would affect, for example, cancer patients, and the day after, recommendation regarding treating patients. So it was really, really impressive. And the very last, but very important point is that palliative care and ethics was also a very important part of the response to COVID infection. I just give you an example. What do we do with a patient with glioblastoma undergoing radiation therapy? If he had the COVID and a severe COVID infection, we had to deal with it, send him to the emergency treatment unit, or just give palliative care. This was very important to deal with it, and these were difficult questions we had to deal with. Another aspect of the emergency response in France was to use radiotherapy departments as radiology departments. Our CT scans were used to screen for COVID infection in our patient, but not only in our patient, in all kind of patients. Because since PCR was not so easy to have because reactives were missing, CT scan was used, as you can see in this recent publication of our colleagues in Paris, to screen patients and to screen staff for suspicion of COVID infection. And this is exactly what we did in Nantes, because our PCR machines were used by the hospital for treating patients with COVID, and dealing with our patients, we could only use the CT scan to make sure that our patients were not affected by severe COVID infection. What about pediatric patients? At the beginning of the pandemics, there was no precise information about how kids would deal with the COVID infection. This paper was published a bit later, but it relates exactly what happened in the US, showing that the rate of SARS-CoV-2 infection among asymptomatic pediatric patients is very low, which was, as I have to say, totally unexpected. We would have expected that kids would have been the most affected people. Second very important information was that the overall morbidity of COVID-19 in pediatric patients with cancer was actually quite low, with only 5% requiring hospitalization for symptoms of COVID-19. But also an important thing regarding kids, it's of course their family. And unrecognized SARS-CoV-2 infection in asymptomatic caregivers is a major infection control consideration. But at the same time, we could see a few reports from different countries across the world. And the left panel is from Algeria, and the right panel is from France, showing that actually a few kids were at higher risk of severe COVID-19 infection by a threefold increase. And this was especially the case in immune-suppressed kids. And by immunosuppression, it means chemotherapy, especially high-dose chemotherapy and stem cell transplant, bone marrow transplant. Use of steroids was at that time considered as a risk of immune suppression. And of course, and this is important for us, radiation therapy, especially large fields such as medulloblastoma, treating a large volume of bone marrow. So why is there such a difference between kids and adults? As you know, and this is probably the case in most of our countries, most people who die of are usually less or people with comorbidities aged 50 older. Children, there is a lower A2 expression in the nasal epithelium, which limits the risk of getting infected. And of course, there's also specific parameters relating to kids, which is the response to viruses, which is a very important part of their immune education during the first years. So basically, kids present an enhanced interferon gamma and IL-17A response. And this is important to dampen the cytokine response to infection. And of course, kids are used to get infected, so they have a milder monocyte macrophage activation. And of Tregs is more important. So this is of importance since we know that in adults or in immune suppressed people, the most problematic issue regarding with COVID-19 is this cytokine storm, which is an over-expression on an overreacting immune system, which is obviously the main cause of deaths in young patients and also in older patients. So emergency was very important in this very anxious period. And rapidly, the French Society of Radiation Oncology, with our colleagues of the French Medical Physics Society, published extremely rapidly, just a few days after the outbreak of the pandemics in France, as you can see in March 19, to recommend what had to be done regarding radiation oncology. And the main message was that oncology remains a priority. Most parts of the hospital that were not dealing with COVID had to stop. Planned surgery was stopped. Planned visits for routine patients. But oncology remained a priority and basically didn't change at all. And the society published emergency care for treating victims, course, and other national societies, and recommend also that was considered as non-essential for treating patients, such as, of course, teaching. So we had to send back a few medical students that were not used at the hospital back to home and give lectures only for limiting the number of cases. And research, of course, had to be stopped for a couple of months for all of the reasons. The emergency response was published for kids, and this is one of the first papers that was published by a few colleagues, Eric Bouffet from Canada and the colleagues from the US, with an early advice on managing kids with cancer during the pandemic. Basically, the message was that we had to deal with kids as we had to deal with adults in terms of physical isolation. So most of the time we had to recommend confinement at home, single room admission, limited outpatient visits, and of course, use as much as possible other means of communication, such as phone or video. That was, of course, important. Similarly to adults, we had to screen patients who present symptoms and limit access to pediatric wards and clinic space to one patient, to one parent only. Of course, similarly to adults, we had to create a COVID-19 free site for delivery of cancer care, and that had to be, of course, separated from COVID suspected or COVID positive patients. We had to think of transferring to remote monitoring as much as possible, but this is something which is very difficult in kids because physical examination is, of course, important. Kids don't always speak about their symptoms, and you need a careful physical examination to make sure that they are not, for example, infected or suffering from something. We had, of course, to use appropriate personal protection. And most important, and this is the main message of all of these presentation, is that we had no reason to discontinue daily activities in pediatric oncology. It was still important as SARS-CoV-2 infection, and probably even more important regarding the total number of patients who die of cancer as compared to COVID. So this is another recommendation from the ASCO saying that most children will have a mild viral disease, but a small proportion will have severe disease. Risk factors are quite unknown, but it's probably more or less related to immune suppression and, for example, hematopoietic stem cell transplant. What is important is what we need to figure out is that the pandemic has created additional obstacles for diagnosis and quality care for children across the world. I mean, it was a very difficult time for all patients and all physicians and clinical staff dealing with that. And very important, especially for kids where research is intense, enrollment in clinical trials has been largely affected. So, of course, the unintended consequences of the pandemic highlight the pressing need to consider vulnerable populations such as kids with cancer. This is a very important message that was repeated very frequently. So how could we deal with it? This is something which is not specific to pediatric radiation oncology, but that was published, as you can read, mostly for prostate cancer, but we can probably use it as a general way of thinking about adapting radiation oncology for pediatric patients. Remote visits, avoid radiation, defer radiation, or shorten radiation. I will try to give insights from all of these different possibilities. Is it possible to use telemedicine in place of personal visit? Is it, as I told you, is it probably difficult for kids? If you want to treat a kid with radiation therapy, you need time, a lot of time, several hours of getting confident with the kid, and in order to make the kid confident of the radiation oncology department environment, specific environment. There is a lot of anxiety at the beginning of the treatment, and we, of course, cannot make it possible remotely. So kids had to come. We had to talk to them, play with them, and get them used to their future treatment. Avoid radiation. Was it possible to avoid treatment for patients where there would have been no benefit of treatment or limited effect? No evidence for quality of life? I had to say that actually pediatric radiation oncology is always something that is omitted as much as we can. You know that the large part of the sequelae of radiation of pediatric cancer is due to radiation. So basically, when radiotherapy is prescribed, it is usually because there is no other choice, no other possibility. The other thing is that sometimes you can use chemotherapy to delay or reduce the need for radiation therapy, such as, for example, brain tumors and especially lower grade glioma. But this chemotherapy can induce immune suppression. So what is worse, getting immune suppression and getting a higher risk of COVID infection, or treating with radiation and avoid this immune suppression? This is, for example, a very classical strategy for Hodgkin lymphoma, which is, of course, something which is trying to, we're trying to reduce the need for radiation therapy as based on the early response assessment. And now, as I could figure it for you in the recent Euronet PHLC2 TL1 group, radiation therapy is used only in the poor responders or inadequate responders. Good responders do not have any longer radiation therapy. So basically, whatever the period during the time of COVID pandemics or not, radiation therapy can be suppressed in a couple of situations. Can we defer radiation? Basically, radiation therapy in kids is one of the few emergency situations, such as, for example, nephroblastoma, but it's been proven that radiation has to be given before the 4th week after surgery. So it's an emergency situation. Similarly, in medulloblastoma, radiation therapy has to be administered within 40 days following neurosurgery. So in this situation, it is quite impossible to defer radiation if you consider that radiation therapy is part of the cure, part of the program dealing to aiming at curing patients. And can we shorten radiation? The first speaker presenting the ASTRO recommendation regarding hypofractionation for neuroblastoma, medulloblastoma. I will add a few more information about treating Hodgkin disease and other hematological diseases, but it's not always possible. And especially if we need to deal with anesthesia, and this is something which is frequently used for kids undergoing radiation therapy. Of course, we cannot remove anesthesia, not to treat them. So we had probably to do as much as we used to be doing before the pandemic, not changing as much of it. This is just to provide you a few guidelines regarding hematological malignancies during the COVID-19 pandemic, and just to show you that even if radiation therapy is usually short in Hodgkin lymphoma or other non-Hodgkin lymphoma, it was also possible to shorten the treatment time to a few fractions, even if I'm not sure that any radiation oncology department really used these recommendations, since we were mostly dealing with patients who were able to undergo a few more chemotherapy. At the opposite, was it possible to use radiotherapy to avoid the immune suppression of chemotherapy? And this is a discussion we had frequently with our colleagues, our pediatric oncologist colleagues. As you know, for example, in the management of pediatric medulloblastoma, the role of chemotherapy is not so well precise, and sometimes, and depending on the stage of the disease and the age of the patient, chemotherapy is used, but radiation therapy is mainstay. The dose of radiation can be modified by the use of chemotherapy, and chemotherapy is sometimes used for younger patients to delay the need for radiation at later times, and trying to treat the kid when he is maybe 6 months, 1 year older, in order to protect the brain. But another possibility is to hyperfraction radiotherapy. And this is something that was tested in different trials. And we know that hyperfractionated radiotherapy, basically 2 1 gray fraction per day in the morning and in the afternoon, is not superior, but not inferior, and probably similar to standard radiotherapy. But the thing is that using this kind of treatment, you can probably treat to a higher BED without affecting the toxicity. And this is something important. Even if hyperfractionated radiotherapy in medulloblastoma is not recommended because it does not improve survival or even free survival, the toxicity doesn't seem to me so much important. And especially, even using a total BAD that was higher using hyperfractionated radiotherapy, the ototoxicity to the cochlea was not higher. And very important in the treatment, in the standard treatment arm using chemotherapy, 20% of the patients prematurely discontinued chemotherapy due to toxicity. So in tumor boards, we considered during this COVID pandemic that it was probably a better option to use hyperfractionated radiotherapy only without chemotherapy to try to avoid as much as possible the chemotherapy-induced immune suppression and try to provide the best treatment with the less possibility of sequelae for kids. And this is exactly what we did with a few medulloblastoma patients. We went back to 1 gray fraction per day for these patients. So how is life now thanks to vaccination? In France, 3 vaccines are approved. For kids, Pfizer is the only one. AstraZeneca is restricted to older patients. The vaccination started in December for fragile patients older than 75 and healthcare providers older than 50, and then was extended to the rest of the population. Now, 88% of the adult population is covered. So we can probably say that the pandemic is almost over in France. So who has to be vaccinated? What is the recommendation? Everyone is who was treated with cancer or were less than 3 years ago, or patients under treatment were a priority for vaccination, especially patients for chemotherapy, and ultra priority was given for patients, of course, with a curative intent, and patients receiving radiotherapy for a primary tumor with a large lung volume or large involvement on lymph nodes or hematopoietic tissue. That was said from the beginning by the scientific societies in France, and our patients were defined as a priority to get vaccinated. And regarding kids, there is no difference in France between younger people with cancer or older people with cancer. And in countries where vaccination is not recommended for kids, they do recommend vaccinating kids with cancer as long as they receive any kind of treatment that makes them immunosuppressed, such as chemotherapy or radical radiotherapy. So to conclude, the main message of this difficult time, in my opinion, is that we experience a great solidarity between physicians, solidarity within the hospital, and solidarity within France. It was a very important thing for us because at 8 o'clock at night, all people clapped hands, especially for nurses, physicians, and all people involved in treating patients. And that was, I have to say, a very important feeling of solidarity throughout the country. And to finish with a very nice picture that was in the front page of the New York Times. And this is a picture of my city of Nantes in France, showing how people put different decorations in the streets saying, thank you for physicians, thank you for nurses, thank you for everyone involved in the COVID treatment. So with this message, I want to thank you for your attention, and thanks again the organizing committee for this very interesting conference.
Thank you very much, Professor Supiot, for this comprehensive and nice presentation regarding the experience from France. I'd like to move the mic to Dr. Majid Al-Uthman to introduce the second presentation, the second speaker. Dr. Majid.
Sure. I think per the schedule, any questions for Dr. Supio should be taken care of now before we move on to Dr. Pinzi. So not sure if you have any questions for Dr. Supio. I do have one or two questions for him.
Yeah, nothing in the chat. Tfadal, Dr. Majid, you could start your questions.
Well, first of all, thank you so much, Dr. Supio, for an excellent talk. I know that dealing with pediatrics is very challenging. My first question is about something you alluded to, which is the anesthesia. Were there any difficulties you ran into with the anesthesiologists in terms of doing that with included intubation, etc., during the heat of the pandemic? And my second question is about also the children who are less than 12. Do you see that vaccination is coming or not likely in their case? Thank you.
Thank you. This is, of course, a very important topic. Anesthesia is mandatory for kids below the age of 3, and we were not able to change that during the 2 months of the first wave. After the first wave, everything went back almost to normal in the hospitals. But during the first wave, we had to struggle to keep on treating kids with anesthesia. And this was a very difficult part, depending on where you were working in France. Of course, in Paris, it was tougher, very hard to get anesthesia. But as much as we could, we kept on using anesthesia during this period of time. The second question is about vaccinating kids younger than 12. This is, as I read, already approved in the US for one treatment, but the discussion has not started yet in Europe. The thing is that, of course, kids with immune suppressed kids would be perfect candidates for this vaccination. But of course, we know that, of course, immune suppressed kids do not respond well to the vaccine. So the thing is now probably to treat them give them the vaccine and monitor their immune response, and give them maybe a second, a third, a fourth shot until they get antibodies. And if they don't get any antibodies because immune suppression is too low, then stop. That's what we do usually with B hepatitis, for example.
Excellent. If no further questions.
Thank you, Dr. Majid and Professor Supiot. If you allow me, Dr. Majid, I have another question for Professor Supiot.
Please, go ahead.
Did you have any mandatory screening for pediatric patients undergoing radiotherapy? And if there is it based on interval or based on symptoms, or you just treat patients without screening?
During the first wave, we try to screen clinically only because, as I told you, PCRs were restricted, and we used only CT scans for people with symptoms. After that, kids were, of course, screened during the second, the third wave of the pandemic situation in France. Kids were screened as much as possible, and of course, basically, mostly depending on the symptoms in their community, with the parents in their school, or of course at the hospital, but no more than other kids. So we had a screening policy in France that was adapted to any kind of person who was in contact with another, and that was not more intense in kids with cancer.
So what about pediatric patients receiving treatment under anesthesia? Do you have mandatory screening for patients undergoing these procedures under anesthesia?
Yeah, any kind of treatment needing a prolonged hospitalization needs to, this kind of patient need to be screened prior to being hospitalized. But for routine daily treatment, they don't need to.
Thank you very much, Professor Soupyot, and thank you, Dr. Majid. Tfadal, Dr. Majid.
Thank you so much. So we go from Milan, France to Milan, Italy, with Dr. Valentina Pinzi. Dr. Pinzi is a prominent radiation oncologist. She's heading the neuro-oncology chapter in the Italian Association of Radiation Oncology, as well as an associate editor in medical journals. She completed her medical school in 2002 in Rome, and then became certified from University of Milan as a radiation oncologist. She also holds a PhD in translational molecular medicine. So the focus of work with Dr. Pinzi is neuro-oncology, and today she will share her experience with us. Thank you so much, and welcome, Dr. Pinzi.
Thank you. Thank you for your nice introduction. Good morning, everyone. And I would like to thank all the organizer and the scientific committee for this invitation to join you. Thank you. So I'll share my screen. Sorry. Okay. Can you see my screen?
Yes, we do.
Okay. So, as you know, Italy was the first country in Europe hit by the COVID-19 pandemic. Despite significant differences in contagion rates were found across the country, with northern regions being the most severely affected areas, all Italian radiation oncology facilities were called to respond to the necessity of treating patients at the time of COVID-19 outbreak. And Italy has been the first Western world country massively hit by coronavirus disease 19. Since the first reported local transmission on 21st February 2020, the outbreak mainly involved northern area, with Lombardy standing out as the second region with most deaths worldwide after New York State, but with half of the population. For these reasons, with reference to the ministerial recommendations drawn up by initiative of the Scientific Technical Committee of the Civil Protection in the context of the emergency situation due to the spread of SARS-CoV-2, the Italian Association of Radiotherapy and Clinical Oncology has therefore prepared a guidance document for its members and all the radiation oncologists operating in Italian during the COVID-19 pandemic emergency. This guidance document, which includes the list of priorities in radiotherapy, the analysis of the respective problem, shared procedural proposal, makes use of ministerial references and experiences already gained in the national territory, already included in the society website. So let's see in more details the priorities that are listed in this document. Each priority is analyzed and then a procedural proposal is defined. So priority number 1 is ensuring radiotherapy in oncological patients. Number 2 is safety of healthcare professional and patient. And priority number 3 is the management of COVID-19 suspected or positive patient in the Department of Radiotherapy. The triage evaluation of the suspect patient for the onset of typical symptoms not correlated to the oncological disease, of course, must implicate the immediate reporting to the designated company body, and in any case, in accordance with the existing regional regulations. Based on test results, the suspension or continuation of treatment is dependent on the individual clinical case. Continuation must be permitted by the local health authorities and carried out under condition of maximum safety for healthcare professionals. Priority number 4, rationalization of the healthcare professionals working at the Department of Radiotherapy. Medical, technical nursing, carers, and administrative staff must operate in separate areas, avoiding working activities or meetings without the safety distances required for prevention. And priority number 5, reduction of patients' access to radiotherapy facilities. About this priority, I would show you the entire text of the document, analysis of the problem. It is recommended to limit access of patients to the radiotherapy facilities in terms of visits and number of treatment sessions in accordance with international and national guidelines and cooperate oncological therapeutic diagnostic pathways. As procedural proposal, we have to promote those hypofractionation when indicated, to procrastinate follow-up visits where possible, to use medical symptomatic treatments if possible at home, if they are considered to be of similar efficacy, and to delay treatments for some pathology like breast, prostate cancers, evaluating the risk-benefit ratio in each individual case, and to postpone radiant therapies for benign and functional disease. This document has been the base of radiotherapy facilities reorganization. But I would show you also some Italian experiences of management of radiotherapy activities during this pandemic for radiotherapy in general. First of all, there is this survey in order to investigate how radiotherapy directors in Northern Italy, in Lombardy in particular, have managed the crisis. An online questionnaire with 27 questions via Google Forms was sent based on the first published COVID reports. So this questionnaire was sent to 34 board of directors of radiation oncology department in Lombardy. 91% specialists anonymously completed the survey. This report shows how Lombardy radiotherapy departments have rapidly coped with the COVID-19 disruption. Significant reorganization has been carried out in a short time with conversion to COVID-19 activities, wards, physician transfer, everything, in changes in radiotherapy practice. The priority was a balance between cancer patient care and safety while protecting the healthcare professionals and providing any possible support in COVID-19 activity. And the results of this survey show us that within a few days of the outbreak, more than 75% of hospitals became COVID-19 centers. Following institutional indications, more than 80% of directors decided to interrupt or modify radiotherapy for some pathologies, preferring short-term treatments and home assistance where possible. About a half of centers reduced their clinical activity by 10 to 50%. Most hospitals, the 84%, canceled outpatient follow-up visits, and some, almost 60-70%, activated telematic consultations. Triage procedures were adopted in all centers. Almost a half of centers registered COVID-19 positive or suspected patients, and for some of them, treatment was suspended. Nearly all radiotherapy centers declared that they would provide healthcare staff with surgical mask and glove, while only few of them also made other personal protective equipment available, including class 2 and 3 filtering face pieces. This is another survey published by Italian radiation oncologists. It provides a real-world picture of the clinical management of non-small cell lung cancer patients in Italy during first wave of COVID-19 emergency. Just a few words about that. Although the majority of Italian thoracic oncologists have proven to follow both national and international treatment guidelines, even during this difficult period, major concerns regards the selection of second or further lines of treatment, as well as the clinical management of elderly population, characterized by the potentially unfavorable risk-benefit ratio. The most relevant issues emerging from this survey included the significant delay of lung cancer diagnosis, and the dramatic decrease of patients' accrual within clinical trial, while telemedicine demonstrated to be a valid support to facilitate patient healthcare interaction. Another paper shows us a picture of the Italian situation after 2 months from the beginning of this pandemic. The authors reported their experience. Patients on active treatment underwent SARS-CoV-2 screening according to the same criteria. They were also guided with detailed instruction regarding social and hygienic rules, required to wear surgical masks, sanitize their hands when accessing the department. Since the beginning of March, all the people accessing this hospital, but in general whole hospital, were screened for body temperature. In addition, the authors reported they established a daytime phone counseling service for cancer patients seeking medical advice. The attending physician was also responsible of the internal triage procedure run in a dedicated room to evaluate the subjects with suggested symptoms. The treatment priority for each indication was evaluated on the characteristics of the patients and the disease, following general principles that were tailored on a case-by-case basis. Priority was given to treatments with curative intent and which effectiveness could be significantly affected by delay. All the procedures that could be deferred without an outcome impairment were postponed. Prescription of palliative radiotherapy was shifted, when possible, towards modulation of analgesic or systemic treatment. Scheduled follow-up visits were replaced by telephone interviews whenever possible. Reports of imaging and laboratory tests were transmitted by email, fax, or retrieved from the hospital archive, examined and compared to previous evaluations by a physician that afterwards contacted the patient to ascertain his condition and list a new appointment. Radiation treatment of positive or symptomatic patients, according to their clinical condition, was performed on a dedicated accelerator at the end of the shift to avoid contacts with other people, using the appropriate masks and carefully sanitizing the room after each treatment. This paper is focused on one part of Italy. However, reflects the approach of the entire population, and their results corroborate the feasibility and safety of continuing anti-cancer treatment by endorsing consistent preventive measures, mitigating some concerns that were previously expressed and that all of us had. The authors suggest to consider the risk of severe infection on a case-by-case basis and balance it with the effects generated by treatment delay or interruption. Moreover, the authors highlighted that hypofractionation should be considered when feasible on a case-by-case basis, both to reduce the number of accesses and therefore limit the risk of infection for negative subjects and to complete ongoing treatment for COVID-19 positive, asymptomatic, or mildly symptomatic patients. This is another article published last year. By comparing the center's treatment activity under ordinary routine condition within the same time interval during full lockdown phase 1, no changes were observed in the number of services performed. So the authors published the organizational model implemented in their experience, respectively during the lockdown phase 1 and the post-lockdown phase 2, ensured an optimal continuity of radiotherapy workflow without reducing workload or interrupting the radiation therapy cycles, as well as the safety of cancer patients, the hospital environments, and the radiation oncology staff. It is therefore recommended that each radiation oncology center customize its organizational model for the management of COVID-19 based on the characteristic and directive used in the university hospitals. This is the list of the procedure for reorganization Briefly, they performed a full maintenance of simul CT, dosimetry activities, radiotherapy treatments, preferring the incorporation of hypofractionated skins. Temperature was checked prior to entering the department. Wearing masks was mandatory. They had triage area. Only 4 patients at the time were permitted entry with a distance of at least 1 meter, of course. All symptoms were analyzed in accordance with the Ministry of Health guidelines. Oncological follow-up visits were interrupted during the lockdown phase 1. Consultation by telephone was made with patients with laboratory and instrumental exams viewed by a telematics. During this period, oncological reopened with 2 shifts daily and appointment spacing of 1 patient every 45 minutes. Lastly, I'll share with you the experience of our head and neck national group. Under endorsement of our National Society Executive Committee, a panel of 15 radiation oncologists with well-recognized expertise in head and neck cancer drafted a preliminary set of items focusing on patients' management and healthcare personal protection at the time of COVID-19 pandemic. Overall, recommendations were tailored on patients without any COVID-19 related symptoms. All patients were therefore considered as potential carriers requiring specific caution to minimize the risk of cross-infection between patients and healthcare provider. The whole RT workflow was considered, from first outpatient consultation to follow-up procedures. Special attention was given to the sanitization of personal protective equipment and sanitization measures of the work environment. The aim of these practice recommendations by our society was to provide a decisional framework for radiation oncologists treating head and neck cancer patients that are very weak patients, very frail patients at the time of this pandemic. The others found agreement for general recommendation, for special recommendation. These are the general recommendation and the special recommendation. Just a quick look. Well, last paper on general radiotherapy management on COVID-19 pandemic in Italy is focused on another important issue, that is the immunosuppression induced by anti-cancer therapy in a COVID-19 positive asymptomatic patient with cancer that may have a devastating effect and eventually be lethal. The incidence of asymptomatic and pre-symptomatic SARS-CoV-2 positive patients ranges from 5% to 80%. According to the University of this hospital, triage procedures, all candidates for active cancer treatment, chemotherapy, radiotherapy, targeted immunotherapy, were pre-screened for COVID-19 infection by a phone call the day prior to the planned day hospital admission, and were advised not to go to the hospital, of course, if they had symptoms suggestive of COVID-19 infection or had a close contact who was COVID-19 positive and was awaiting for test. All patients planned for immunosuppressive anti-cancer therapy had blood cell count done at a local laboratory nearby their homes, and they were advised by phone not to come to the hospital if blood cell count was too low to be able to receive therapy. In addition, on the day planned for anti-cancer treatment, patients undergo the standard clinic triage procedures based on their personal and family anamnesis for COVID-19 infection and symptoms, vital signs, and temperature check. The authors found that rapid serological testing added to standard clinical triage at hospital admission failed to detect active asymptomatic COVID-19 infection. And also, rapid serological testing entailed additional economic and human resources, a complex rearrangement of their hospital activities, delayed therapy administration by at least 24 hours, and increase hospital accesses. So they concluded that more sensitive and specific serological assays are needed. All patients who need cancer-active immunosuppressive treatment should be screened with real-time PCRs as SARS-CoV-2 testing, as it has higher sensitivity for COVID-19 detection and currently represent the gold standard. Implementing different strategy for COVID-19 detection in patients with cancer may be critical to identify asymptomatic cases. But let's have a focus on radiosurgery. Since late February 2020, hospitals in Italy, in particular in Lombardy, began admitting an increasing number of patients with COVID-19. Elective surgeries were halted and operating rooms were converted into COVID-19 dedicated intensive care units. In mid-March, neurosurgical elective activity ceased, and oncological and traumatic cases were then referred to the dedicated hub hospital. Almost all doctors from all specialties have been called to support physicians, infectious disease specialists, and respiratory physicians. Currently, there is a paucity of literature guiding radiosurgery practice adjustments during an event like COVID-19 pandemic. Although guidelines have recently been published regarding a triage algorithm for neurosurgical cases in the setting of COVID-19, no guidelines exist on how to balance the risks and logistical challenges associated with optimal and timely delivery of radiosurgery during this crisis. Radiosurgery is frequently utilized in the management of intracranial malignancy, benign tumor, vascular malformation, neuropathic pain. Truly urgent, emergent intracranial pathology is rare with radiosurgery. Thus, patient-specific consideration for radiosurgery should be given for patients harboring malignant secondary or primary neoplasms in semi-urgent fashion. In this table, Brettler classified radiosurgery indications as electives, semi-urgent, and urgent. The author defined elective a radiosurgery treatment that may be delayed indefinitely with minimal risk of adverse consequences or treats condition that can be managed medically. Semi-elective treatment that should be performed within 3 to 6 months to avoid adverse consequences. Semi-urgent are those treatments that should be performed as soon as possible, might be delayed over 48 hours. And the pathologies that we well know are brain metastases, primary intracranial malignancies, rapidly enlarging lesion, or compression. As urgent, emergent indication, there is no one for radiosurgery, because when we talk about urgent intervention, usually it requires acute or subacute surgical intervention in less than 24 to 48 hours. So factors that drive the decision to proceed with radiosurgery will include clinical and radiographic tumor characteristics, patient prognosis, and whether alternative therapies such as chemo or immunotherapy may be pursued in lieu of radiosurgery. Therefore, when compared to standard fractionated radiotherapy, which requires between 10 to 30 hospital visits, radiosurgery stands out as an ideal alternative. When compared to surgery, radiosurgery does not require endothoracic intubation or the use of high-speed instruments, lowering the risk of exposure to infectious aerosols and bone dust present in open procedure. This is an experience of an Italian radiosurgery center. The authors described a safe treatment pathway for patients in need of cranial radiosurgery during the COVID-19 pandemic. They adopted some precautions. Only one patient was treated per day. All healthcare workers were radiosurgery dedicated, excluded from COVID-19 units, and appropriate personal protective equipment was used. The author The authors described a safe treatment pathway for patients in need of cranial radiosurgery during this pandemic. Treatment pathway for radiosurgery was performed as an outpatient procedure that spanned 2 days. During the first day, the patient underwent COVID-19 nasopharyngeal swab, chest computed tomography, routine blood tests, and infrared body temperature check. The second day, if all those exams and physical examination had ruled out COVID-19 infection and related syndromes, the patient was admitted to the center. After arrival, the patient washed their hands with sanitizer, stored in a locker all personal belongings. Peripheral pulse oximetry was placed to assess oxygenator status, and the stereotactic head frame was fixed. The patient was transferred to radiology procedural suite and backed by traveling in a wheelchair. Stereotactic magnetic resonance imaging was acquired, and radiosurgery was performed. At the end of the procedure, the frame was removed in their experience, and the patient was discharged home. Finally, the radiosurgery radiology rooms were sanitized and disinfected carefully. In another letter, the same authors highlighted the need of reorganize the radiosurgery units to modify the normal current workflow at the hospital, adopting different solutions to protect our patients and health professionals, postponing non-urgent treatments in the event of catastrophic natural events like earthquake, hurricane is normally done, but this pandemic event is very different. Stopping all treatments for such a long time will not be possible, is not possible. Furthermore, a second peak, a third peak, we don't know, may be possible. In many instances, radiosurgery represents an ideal non-invasive treatment modality in the current pandemic setting, as it is performed as an outpatient procedure with minimal personal protective equipment, typically requiring only one session. For patients with malignant tumors in whom both open surgery and radiosurgery are credible options, the present scenario would favor radiosurgery. On the other hand, radiosurgery is a multidisciplinary practice involving radiation oncologists, neurosurgeons, physicists, and radiation therapists, with crucial supporting roles played by neuroradiologists and nursing staff. Many high-volume radiosurgery programs use case review conferences to review cases, triage proposed radiosurgery procedures, and optimize treatments to minimize risks to patients and providers. In the past, such conferences, I think, as we all know, were done in person. The need to practice social distancing has prompted and moved to online platforms for these conferences, as we are now. Fortunately, the nature of radiosurgery case review allows easy adaptation in most centers to continue these conferences remotely. In conclusion, I'll show you some tools for mitigating risk of exposure on radiosurgery setting. Apart from the well-known protection measures that are listed here, for radiosurgery, we have to consider to develop agreement on definitions of what is considered to be an urgent case for stereotactic radiosurgery. Conservative indication might include symptomatic or enlarging brain metastasis and spine metastasis with proximity to spinal cord, conus, or producing intractable pain. More liberal indications would extend treatment to patients who were not symptomatic and who did not have a systemic targeted immunotherapeutic option based on their cancer's genomic profiling. Other extenuating circumstances, such as projected loss of access to medical care, should be considered, of course. Moreover, we should consider immobilization devices to be contaminated, particularly for cranial radiosurgery, irrespective of radiosurgery treatment platform. Stereotactic frames are in close proximity to nasal and oral secretions. Face masks are in direct contact with nose and mouth. Even the fiducial marker stickers that are placed on the nose for certain type of frameless radiosurgery should be managed as a contaminant item. We should minimize number of fractions. Another strategy to minimize contact and help with decreasing the flow of individuals into the hospital is to focus on minimize the number of fractions in our treatment plans whenever feasible. As a result of the COVID-19 outbreak, our center has been reducing the number of fractions for fractionated cell retractology surgery. For example, also for selected cases, of course, for primary brain tumor like glioblastoma. Finally, we have to consider single fraction radiosurgery for multiple brain metastases rather than whole brain radiation, if clinically reasonable, of course, as the latter requires 10-50 sessions, while the former can be accomplished in one single session. If the number of metastases is too large for treatment with single fraction radiosurgery and a few dominant metastases can be identified, we can consider single fraction treatment of those lesions with salvage additional radiosurgery or whole brain radiation in the future. And lastly, we should use systemic therapy as a temporizing measure, especially if indicated for systemic disease, if there is some particular cases, and minimize use of corticosteroids due to the risk of inciting or exacerbating immune suppression. So thank you for your attention. And so I will stop sharing my screen.
Thank you so much, Dr. Pinzi. That was an excellent talk. And thank you for sharing your experience. Really, maybe because I don't see any written questions, I will start with using this time to learn from you. One often ignored aspect of COVID-19 is the media coverage. And to say the least, that the media coverage about Italy was a bit concerning, and we don't know what the truth is. And maybe you are there, you're in the field, you're in the trenches, you can kind of let us know what was the situation, and not to get into the details, but just to see the impact on the spirit and morale of the medical staff. And how did they keep their spirit and solidarity, as Dr. Supio mentioned, in face of the concerning news?
Well, yes, there was last year a very difficult situation because it was a situation rapidly increasing in the dramatic difficulty to manage all patients with COVID-19 infection and all our patients that were scheduled that needed treatments. So there was a difficult situation because it was suddenly changing our practice. But well, there was also a great collaboration, and we shared our moments, difficulties, but without thinking about fear or about I don't know. Sometimes we had also the masks, not surgical masks, because we had. But at the beginning, we weren't absolutely ready to have whole masks of level 2 and 3. So it was really difficult to manage the triage and different patients. But solidarity, as the previous speaker highlighted, has been the most important things. Solidarity that was shared not only between us, but also with other countries, because, for example, we were in touch also with French colleagues and Spanish colleagues and all colleagues around the world. However, after 2 months of sort of not panic, because we were not in panic, but we had actually an important emergency. First of all, to reorganize everything, to reorganize our routine, to reorganize our patients. And one of the main difficulty with patients was to, for patients, understand that we couldn't maintain our usual activity of visit very close, talking a lot with patients. They were like, oh, I cannot, it's difficult, but I think this is experience of all of us. For us, was the difference was in the suddenly changing situation. For radiosurgery, we actually could manage everything. Of course, at the beginning, we stopped not urgent patients like meningiomas, neurinomas, or well, also other grade 1 or grade not aggressive pathologies, metastasis, recurrence of primary tumors. We continue to treat all patients using all these measures that I have mentioned, that all of us know, and well, we are here.
Wonderful. That's very inspiring, Dr. Pinzi, and thank you for sharing your experience. And I think we need to move on to the next talk. Dr. Al-Maghrabi?
Yes, thank you. Just for the third presentation, I would introduce Dr. Houej, who's the first resident trainee in radiation oncology in France. And he's the first and the only representative Saudi radiation oncologist consultant working there. He has many scientific and academic activities. Dr. Houej, the floor is yours.
Thank you very much to give me this opportunity to talk about COVID-19 outbreak and radiation oncology services international regulation. I don't know why Dr. Maghrabi chose for me this topic. He told me that I am international. I am Bedouin Saudian who work in France. I will talk today about introduction, challenge for radiation oncology during an outbreak of infectious disease. Then I will talk about consensus-based guideline. Then I will give you some important messages. The first message for me, it is very important. On the pandemic situation, we have extraordinary time, require extraordinary measures. Go through too many international, national and local protocols. I chose this paper and protocol for many things. I will tell you why. On 11th March 2020, WHO director declared the novel coronavirus outbreak with over 118,000 cases and more than 4,000 deaths. And this paper is received on 20 March, revised on 22 March, and accepted on 22 March and available online on 24 March. with unusual methodology. About 121 individuals, radiation oncologists, physicists, medical physicists, and technicians from 17 countries contributed online Twitter discussion on the Radiation Oncology Journal Club tag. They discuss this issue and create some base guidelines. This content was guided by 5 challenges. I will highlight it on the next slide. Patient groups, staffing, environment, and equipment and treatment. And summarized into 3 items: minimizing transmission for maximum social distancing, triaging limited sources qualitatively, and treating patients with infection. There is asynchronous to online conversation with Astro and Astro produced statement, which also support this discussion. The challenge for radiation oncologists and outbreak of infectious disease, we can talk about patient groups. We have mixed population like unwell palliative patients. We treat unwell palliative patient with curative treatment, patient receiving preoperative, adjuvant, or definitive treatment. Staffing, we have a very we have staff. They require very specific skills. That's why we should protect our staff. Our radiation oncology services is not like other normal hospital or acute hospital, where we can send staff from department to other department. Environment, radiation oncology unit have physical separation from the other hospital department, not all of them. And equipment, we have highly specialized equipment, which will usually treat high volume patient in sequence. And treatment, we know that delivered infection and efficacy is influenced by interruption or gaps. I want to talk for minimizing the risk of COVID transmission during radiotherapy, prioritizing treatment, radical treatment, and adjuvant treatment, palliative treatment, disease-specific recommendation. Minimize the risk of COVID transmission during radiotherapy treatment. We should take adequate precaution to reduce the likelihood of COVID transmission. And the most effective way to protect staff and patients from COVID-19 it is to reduce infection rates. We should have updated guideline on self-isolation or social distancing, and reduce the need of patients to attend a clinical environment. And a large amount of follow-up activity can be conducted by telephone or telemedicine. Prioritizing treatment and the situation for a pandemic, we know that the risk-benefit ratio of treatment changes. That's why we can use a simple model of the risk of COVID infection multiplied by risk of a serious morbidity or mortality. For example, old and fragile patient, 5% risk of infection and 10% risk of death from infection. There may be a 0.5% mortality through exposure and attendance for radiotherapy. That's why we should discuss this patient to treat or not treat. For young and healthy, 5% risk of infection and 1% risk of death, then there is a 0.05% mortality from corona. We should expect a shortfall on staffing level. That's why we should protect our staff. Again, creating capacity, we can create capacity by reducing fraction number and sometimes to avoid treatment for some patients. If we talk about adjuvant treatment, we should estimate of risk benefit to continue on to and to justify the treatment. For example, patients who may only gain modest benefit in terms of long-term survival, okay, may wish to avoid radiotherapy and treatment which reduce local regional treatment recurrence rate, but do not improve survival, may be appropriate to avoid. Palliative treatment for symptom relief, we should use all other options like analgesic and biphosphonate. And if radiotherapy is given to painful bone metastasis, we should use the single 8 fraction protocol. For whole brain radiotherapy, we avoid treatment and use the steroid alone. And for stereotactic radiosurgery, we should discuss with every patient. Now, I would like to disease-specific recommendation. If we can talk about radiotherapy that may be omitted, I will give you some example. For example, best conservation and DCIS, we know that there is no survival benefit. But there is small benefit in local regional recurrence. We can avoid the treatment. Glioblastoma aged more than 60 dilated, we can treat them with chemotherapy. There is no radiotherapy. Seminoma stage 1 omit radiotherapy, consider observation or carboplatin. For palliative treatment, where fractionation may be reduced, for example, metastasis, no fracture, plus minus cord compression, we can use the 1 fraction protocol. And supravenous cava syndrome, we can use 8 to 10 gray for 1 fraction. We can talk about radical radiotherapy treatment where a fraction where fraction may be reduced by, for example, a glioblastoma multiforme age more than 65, can use the protocol 15 fraction, and partial external radiotherapy can use the 6 gray 5 fraction, and prostate localized and risk, we can use the 20 fraction 3 gray 5 fraction SHIP and PROVET trials. For rectal preoperative clinical T3-4, we can use 5x5. For radiotherapy treatment that can be delayed, for breast conservation T1, 2, and 0, luminal A and B, we can start the hormone therapy and wait for about 20 weeks for to start the radiation therapy. And prostate intermediate high, very high risk, we can use the hormone therapy and for 6 months, and after that we can start radiation therapy. I would like to talk about four important messages. First of all, extraordinary time require extraordinary measure that guided by the best available evidence. Should follow the program of PCOC, prepare, communicate, operate, and compensate. I want to highlight on this one. Prepare, we should agree change in the treatment plan with colleague and physics. And increase capacity and preparation for reduced workflow, make physical adjustment to a treatment area, order fit and test personal protection equipment, order IT to allow home working from self-isolation, and move clinic plan to remote monitoring, telemedicine, or by telephone. Communicate, explain to patient how COVID-19 changed the risk-benefit, discuss personal protection, safety, hand washing, and infection control, and radiation therapist with daily physical patient contact, alert staff group to any suspected or proven COVID-19 case, and then operate, consolidate staff into small functional group without physical contact, and consider temperature screening for all users of the radiotherapy center, and quickly disseminate information around COVID cases, and agree with patient and staff if treatment will continue with personal protection equipment, or stop or pause the treatment. Then compensate, the last compensate, which when treatment is paused, agree radiological models on the alpha beta value for compensation, and consider reassessing the CTV if growth may have taken place. The third message is remote working practice and reduce fraction regimen, or even not treating, to reduce the burden of this disease in our cancer population. And the last is social media and other digital communication tools have proven a very effective method. Thank you very much.
Thank you so much, Dr. Hawaish, for this interesting lecture and very concise and align with our objective to have like a guidelines during this tough period. I couldn't see any question here. The question to you, Dr. Hawaish, if you have like experience, I knew and I acknowledge you have like a good experience in gynecology. What do you think in terms of using brachytherapy nowadays, either for cervical or endometrial cancer with you? Is it, just the brachytherapy, you omit the external beam radiation or something like that? I need your input for this question.
The problem in France, we have no brachytherapy in every center. That's why every region maybe have one or two referral center for brachytherapy. And if we do not need anesthesia, we can send the patient directly to the referral center, or choice. For example, for the prostate, most of the people are choice the external beam radiation. But for the gynecological treatment where there is no other option, yes, we send them to the referral center or treat them with brachytherapy. There is no change of, normally there is no change of practice.
Yes, just I will keep the door open for any question from the panelists. Please, Dr. Majid, Dr. Ali.
No, I think we need to conclude the session because I think we're over the allotted time. I would like to extend my thanks to Dr. Stefan Supio from France, and Dr. Valentina Pinzi from Italy, and Dr. Hawaish Al-Mukhlas for informing us and sharing this European experience. And I think we have learned a lot. And with this, we conclude this session and move the podium to Dr. Al-Idrisi.
Thank you all. It's a great session, and I really appreciate all your effort and sharing with us your experience. And we look forward that we will continue our collaboration between India and Europe and Saudi, and sharing our update next year with God will. For the time being, just because we're running late, I think because our third session will start at 1 o'clock. So I would like to conclude this session, and we look forward to see you in session 3, which will speak about our Saudi experience and in this field. Thank you all, and we look forward to see you in our last session at 1 o'clock.
Thank you. See you then.
السلام عليكم دكتور ناصر.
وعليكم السلام ورحمة الله وبركاته. أبو صالح كيف حالك؟
معلش بس ترى الاتنديز سامعينكم. انكم تكلموا على الخاص، الظاهر الاتنديز سامعينكم.
We are just to tell them that we are ready.
نعم.
For the next session إن شاء الله.
Sure. Yeah. We'll call you in the private.
We'll start at 1 o'clock sharp.
Yes, 1 o'clock sharp.
إن شاء الله. Okay. السلام عليكم.
وعليكم السلام. So it is 1 o'clock. Dr. Maha, Dr. Maghrabi, and the team.
Start, Dr. Nasser, with your team.
Sure. بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على نبينا محمد وعلى آله وصحبه وسلم. It's a pleasure to have this excellent symposium related to COVID-19 effects in radiation oncology specialty. And I would like to introduce Dr. Adnan Al-Hibshi, who is our lovely and senior radiation oncologist at Johns Hopkins Aramco in Dammam. He will lead the session. I will back him up. Dr. Suleiman Al-Ghamdi, when he joins, he will also support us. Go ahead, Dr. Adnan. Bismillah ar-Rahman ar-Rahim.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Idrisi, Dr. Dibani, Dr. Maghrabi, for the excellent organization. So we moved from the far east of the whole universe to the far west, and now we are back to the middle of the globe. Dr. Mushabbab Asiri, he will be the first speaker in the third session. Dr. Mushabbab Al-Asiri, one of the big calibers in radiation oncology in the Kingdom of Saudi Arabia. He was the chair of the oncology department in the military hospital in the past. Then he was the chair of the oncology department at the King Fahd Medical City. And after that, he promoted to medical director. And now he's the head of the, not only the head of the chairman of the proton and particle project at King Fahd Medical City. Dr. Mushabbab Asiri, he's one of the senior radiation oncologists, as I mentioned, and he's the best person to talk about the outbreak and radiation oncology service as a national regulation. Dr. Mushabbab Asiri, welcome to this symposium, and we are waiting to hear from you. Dr. Mushabbab? Assalamu alaikum.
تسمعوني الآن؟
Yes, very clear. Please go ahead.
بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على رسول الله. Thank you, Dr. Al-Habshi, for this nice introduction, which is a sign of 25 years of love and friendship between me and you, where we share a lot of experience in so many places. And many thanks to Dr. Debani, Dr. Idrisi, for giving me the chance to speak about local regulation for COVID-19 in Saudi Arabia. Also, I don't like the name because it is not having attraction for the people. People still saying coronavirus, only medical staff using COVID, and politicians use such too. I'll talk about the Saudi Arabia regulation for the COVID-19. Is my slide showing up, Adnan?
Very clear. Go ahead, please.
Okay. I have nothing to disclose, and I am I'm presenting this lecture in memory of two of my best friends who passed away and died as a result of coronavirus consequences. Dr. Hamid al-Najjar passed away, may Allah be pleased with him, as consequences of COVID-19 infection. He passed away in Egypt, and he was the vice president of Saudi Proton Therapy Center. And the second friend who was among us last year, Mr. Sayyid Siraj, who was the head of radiotherapy unit in King Abdullah Medical City, and also he passed away as consequences of coronavirus in the United States. May Allah be pleased with him. And I'm just bringing their names as a sign of respect to the great man. And I'm sure there is a lot of friends among all of you who've been a victim of this disease or passed away as a result of this disease. I don't know why I was a little bit attracted to the COVID-19 from the beginning. Maybe I was the first person in Saudi Arabia talking about it when I tweet on January 2020 about it. And also I send a warnings for all the medical staff in emergency rooms and ICU 6 weeks before the announcement of the COVID-19. And this is not a sign of prophecy, but I was in the middle of the storm during the Middle East SARS or MERS-CoV. As we talk now, there is many people suffering from coronavirus in the world. 234 million being infected, 211 million recovered, thanks Allah. And still on the beds of hospital or at home, there is 18 million suffering about this disease around the world, and 4.8 million died as a result of the disease. And the case fatality of the disease is about 2%. While in Saudi Arabia, alhamdulillah, we are not hit as other countries, only 500,000 patients exposed or infected with corona, and 536,000 recovered. We still have around 2,000 patients suffering from the coronavirus, and majority of them at home. Alhamdulillah, only 8,000 died as a result of disease, and the case fatality in Saudi Arabia was one of the lowest in the world, with a case fatality of 1.5. We learned a lot from MERS-CoV lesson, which was 2 or 3 years before the COVID-19. And I think the right move that protected the country, with the thank you for Allah subhanahu wa ta'ala, that the Ministry of Health was aware about the importance of infectious disease consultant, where the Ministry of Health attracted 3 eminent consultant infectious disease, Dr. Abdullah Asiri, Dr. Hail Al-Abdali, and Dr. Mimish. And they assigned the 3 of them as assistant vice minister in the Ministry of Health during the MERS-CoV, because Saudi Arabia was under that tension from all over the world, and we was in the same position as China for the COVID-19. And the infrastructure for such infection was established in Saudi Arabia. And alhamdulillah, when the disease hit next years or 2-3 years later, we were ready to deal with this pandemic. One of the most important things that protected Saudi Arabia with the help of Allah is the infrastructure data. We have an excellent data resources, and it was integrated. And there is National Control Center in the Ministry of Health, where there is millions of data coming from all the health sector of Saudi Arabia. And you can see the screen on the back, where there is live streaming of information from all over the country, from the emergency rooms, from ICU unit, from the test center, and that helped the decision maker to make the right decision. And that's why Saudi Arabia was one of the best country dealing with this disease. At the beginning, King Salman, may Allah protect him, announced the national pandemic in Saudi Arabia in the early of March. And in a few days later, I'll show you in a minute how we dealt with this disease. Even for very difficult decision was made, like emptying Al-Haram al-Sharif and stopping Umrah, stopping coming to Mecca. People, they take it as a very harsh decision, but I think that was the right decision to be taken. And there is COVID-19 Executive Committee at the highest level, led by the Minister of Health, and with participation from Ministry of Defense, Ministry of Interior, Ministry of National Guard, Finance, Culture and Hajj and Aviation, Red Crescent, Trade and Investment, Education, Saudi FDA, Saudi Health Council, Custom, Tourism, and CDC. And by the way, this executive committee was on daily meeting at the beginning of disease. So Saudi Arabia was one of the best countries that dealt with this. It was announced as the first case on the 2nd of March, 2020, and Umrah was closed just 2 days later. And also starting the tele-education on the 8th of March, just 7 days after the first disease announced. With the fourth case in Saudi Arabia, the students start studying from home, and also the public staff was start from working from home just 10 days after the announcement of the first case. So the country dealt with the infection in an excellent way, and I think it is model for other country for protecting the nation from disease. And the major strategy which taken was to cancel all the planned event, use of social distancing, travel restriction, voluntary home quarantine, change of funeral services, restriction of mass gathering. And I think this is the same things that we have to do in health. And also Saudi CDC, which called Wiqaya, start to publish a lot of guidelines and instruction to health worker and for the people in bilingual, in Arabic and English. And we as radiation oncologists participated in the Saudi Arabia National Cancer Institute regulation for coronavirus. Myself, Dr. Majid Al-Uthman, Dr. Ibrahim Al-Utain, Dr. Ali Balbeid, and Dr. Hussam Al-Assaf from Radiation Oncology group participated in the national guidelines for coronavirus in Saudi Arabia, and we published the guidelines. It was updated 3 times at early stage of disease. The first publication was in April 2020. And the general preparation for cancer patient in general, based on, as Dr. Huwaij mentioned in previous presentation, it is about educating the staff, establishing screening procedures, implementing standard precaution, providing protective equipment for the staff, encourage masking, also to do N95 fitting for the staff working with dealing with patients who have COVID-19, and also identify the call center and provide staff and patients with permit during the lockdown. Also, we mentioned the guidelines to limit access to the cancer services to our entry, and that's including radiation oncology areas, restrict visiting or watcher with the patient, and provide identification for virtual support, establishing triaging system, and also establishing social distancing, and suspend all on-site conference. And I remember that one of the first conferences in oncology was when the country locked down. So we also, as oncology people, we suffered from limiting us from seeing each other and exchanging knowledge. And now that's virtual, and I think it's much easier. Also, many things for the patient to adapt telemedicine, provide refill services, and postpone all the non-necessary follow-ups. We also published how to deal with the staff who been exposed to the patient with COVID-19, and it was available it is available now in the site of Saudi Health Council. We also make a standard for managing patient who doesn't have COVID-19. It is just for other patients to be individualized. More important to initiate therapy, and also doing screening and testing for COVID-19 before the treatment, to postpone any unnecessary start, and to adopt hypofractionation. And also it was clear that Rabido hypofractionation regime, and also hypofractionation in prostate and breast cancer was accepted without saying among the radiation oncology during the COVID-19. I think they may change their things later on after the COVID is over, and inshallah COVID will be over very soon, inshallah. Also, there is guidelines for the patient who been confirmed to have coronavirus infection, again to be individualized. The rule is not to start treatment for patient who is suffering from COVID-19, and most of the patients who have COVID-19 patient and treated in the radiation oncology department, either they were discovered during the treatment, not before the treatment, or for the palliative patient. And I think it is just most of the radiation oncology department assign certain staff, whether who have COVID-19 infection before or and also at the end of the service, and to just apply the international regulation for infectious disease patient on radiation therapy department. I think also one of the most important things that we participated in is the introduction of vaccination and mass vaccination in Saudi Arabia at different level, and we announced the importance of vaccine for the cancer patients in particular. And now we also push the Ministry of Health to start vaccinating or giving the third boost for cancer patients. Also, we participated in the Saudi Health Council for opening the theater and opening the service for cancer patients during the lockdown. And also one of the major things that we participated is to support the family of healthcare who passed away as a result of COVID, with reimbursement of 500,000 Saudi riyal, which is around $130,000. Again, we also make a major or consider major importance of educating the patient about how to protect themselves and their loved one during the treatment of disease. At the end, I'd like to thank the panel, Dr. Adnan, Dr. Nasser, and others, Dr. Maha, and also the event group for supporting us during the preparation for this conference. Thank you very much.
Thank you very much, Dr. Mushabbab. Really, I'm very proud from the measures taken by our country, from our king level down to the last person in the health service in Saudi Arabia. Needless to say, the numbers of the COVID-19 infection dropped to 50 per day, and our hospital last week, 0 patient admitted with COVID-19. We don't have any COVID-19 patient in our hospital, which is really achievement. This is based on the excellent regulation performance from all the levels, from the government level to the health service level. Thank you very much. Really, we feel very proud that our country now in the green zone of the COVID-19 infection. This didn't come from space. This came from a lot of effort from everyone. Thank you very much. Also, thank you, special thank for the radiation oncologists who did this excellent organization during this pandemic. If anybody have any question for Dr. Mushabbab, or I can move to and we'll make the question at the end. I cannot see any questions active now in the list. Thank you very much, Dr. Mushabbab. It was an excellent presentation. Really, we are very proud from your performance and the others and everybody in the health service. Next patient, sorry, not next patient, actually. Next presentation for one of the senior radiation oncologists in the Kingdom of Saudi Arabia. He was the previous head of the radiation oncology at King Saud University Hospital, King Khalid University Hospital, and now he's a consultant of radiation oncology, one of the senior radiation oncologists, one of the really milestones of the breast radiation oncology in Saudi Arabia. Dr. Iyad al-Saeed, who was graduated from University of Ottawa as a radiation oncologist, and he practiced at King Saud University Hospital, as I mentioned. He will talk about the COVID-19 outbreak and breast cancer hypofractionated radiation therapy. Would you please start, Dr. Iyad al-Saeed, without any further ado? Dr. Saeed, can you hear me? Anybody can help us from the IT, please, regarding Dr. Saeed? We cannot hear him.
No, we cannot.
We can see his. We can see his presentation, but not maximized.
Yes.
Yes. This is the voice I waited for.
Okay, thank you, Dr. Habshi. I'm sorry there is something happening in the mute. So I would like to thank your introduction first of all. And I would like to thank the organizing committee for this organizing such an excellent meeting, which is important to us to share information and maybe changing even practice. So I'm gonna talk, in my talk, I'm gonna talk about experience, my special experience and my institute experience dealing with breast cancer during the outbreak. As an introduction, this pandemic started in China, December 2019, and started to be pandemic in 11th of March here in Saudi Arabia. As Dr. Asiri mentioned, first case was in 2nd of March. And in the 10th of May, suddenly, while we are treating your patient, they told you that there is a quarantine and you have to reduce the number of your service by 50%. 50% of the staff should be working and 50 off. And this confuse you and make the patient, your patient, especially breast patient, you know, they are always anxious to be delaying her treatment and waiting for further notice. So the logo at that time is stay at home as much as you can, because there is a pandemic, you may get disease and it can affect your life. So what should we do? Should we just stop treating patient or to prevent them from getting infection, or we should do some strategy? So some strategy was mentioned this morning and afternoon by Dr. Asiri is to go with remote visit as much as we can, if we can avoid radiation, and if we can defer radiation. But this is not a long-term solution. The solution is to shorten radiation time. So you bring the patient to your hospital less time, so less incidence and risk to get infection. So remote visit, we tried as a physician treating breast cancer to minimize the time in the room by doing much remotely possible and limiting examination to that which is necessary to inform radiation decision. In my outpatient on treatment visit, I try to check, if needed, the skin of the breast by visualization and by asking the patient to manipulate the breast tissue to show the inframammary and axillary area using all PPE standard by the hospital, required by the hospital, and try to filter my clinic, especially the follow-up, and make it by phone calls unless the patient need to come to the hospital. Avoiding radiation. So any patient, old patient, above 70, or I'm considering even above 65 with a small tumor, less than 2 centimeter, negative lymph node and positive receptors can take hormonal therapy. I started to avoid or at least delay radiation. Patient post-mastectomy, if they have less than T3 disease, less than 4 nodes, we know that there is little benefit as a stratification. I try to delay it or omit it. And all the DCIS with low risk, we omit. In regard boost, we try to do some modification to consider omitting boost after lumpectomy with a low grade tumor, or any patient less more than 50 with hormone receptor positive, low grade, widely negative, we start to omit. Or some patients we consider to give the integrated boost by using IMRT and VMAT to shorten the time. Some institute, not in King Saud, they're using the boost as an intraoperative. So you preserve 1 week of visiting the department. The third strategy is defer radiation. Can we do that? We in the beginning of the pandemic and after May, the decision of quarantine, we tried to do it, but sometimes we cannot. So we started to prioritize patient to A and B and C. So A, for example, they cannot delay. Okay, you cannot defer the radiation. So patient like having bleeding or painful inoperable breast, patient already on treatment, or patient with spinal cord compression should be treated. Priority B is the patient with the adjuvant treatment. We can delay 6 to 8 weeks and see then what will happen. And priority C, as we mentioned, the low, very low risk that can be even omitted. But still, as I told you, it's not the final, the long-term plan. The long-term plan is how to reduce the number of your patients to the department. And breast cancer is a common breast in Saudi Arabia. It's the commonest tumor in all the world. High incidence, so high people coming to you in radiation therapy. If we calculate that 50 to 60% of breast cancer gonna come to your department for adjuvant treatment. So the story of hypofractionation and breast cancer was not because of the pandemic. It was not to solve the problem during the pandemic. It was a long time ago because it is hectic for all the leader in radiation oncology department because they are having a long waiting list and exceeding the capacity of their department. So as a history, we go back a little bit in a history, these hypofractionation started a long time ago. In 1993, the Canadian study by Whelan randomized the patient to 50 and 42. So they are trying to shrink 9 days of treatment and stratify the patient according age and size. And there was no attempt to give any lymph node or boost in this study. And they found in the study, and the risk of local recurrence in 10 years, it's good. 6.7 in the 50 group and 6.2. So why don't we hypofractionate more and more if there is good result with good toxicity? Even they found that the side effect is good, and it is much better in the testing group. So the world started. They were so active in the 90s, finding a shorter scheme because breast cancer was hectic, too many cases. So the UK liked the idea, and they start to do open trials, which is START trial A, giving hypofractionation radiotherapy. So in 1998 to 2000, they recruit 2,236 patients with PT1 disease, N1 to N0 disease. And there was 2 types of surgery in these cases, but the dominant in the study was the post-breast conservative surgery. So this is the criteria, and the endpoint of this study was the local regional tumor relapse and looking for the late normal tissue. So usually in hypofraction, the hectic things and the things that getting the physician worried is that the breast will not tolerate and they will have too many side effects. So this is the randomization. They randomize the patient to 50 and 25 and 41.6 in 13 fraction over 5 weeks and 39 and 13 fraction over 5 weeks. And they found that the result between the 50 group and the 41.6 group is similar after 5 years, 3.6 versus 3.5, although in the 39, 5.2. So they discovered this is low dose. And they found that the side effect is a little bit low in the 39 compared to the 50, but similar between the 41.6 and 50. They had updated us in their result in 10 years follow-up, and they found the local recurrence still high in the 39 group, but it is not significant difference between the 41.6 and the 50 gray group. So at that time, parallel to this study, there was a START B, a protocol open between 1999 and 2001 with the same organization and design, but different scheme. So they tried to randomize, they randomized the patient to 50 gray in 25 fraction and 40 gray in 15 fraction. And we found it's equal or maybe much better in the 40 gray group. And the side effect is not a big difference between the 40 and the 50 group. And this is a 10 years follow-up survival showing 4.3% in the 40 gray, 5.5 in the 50 gray. And at that time, 10 years follow-up, we started here, even here in Saudi Arabia, to go more with the hypofractionation. And I'm one of the person that changed my practice from 15, 25, and 42 and 16 to 40 and 15, even with lymph node involvement. So I moved from just breast to even breast and lymph node. So this study, and especially the 10 years follow-up, changed the practice. So the British liked the idea, and they start after the good result, started to have more and more hypofractionation. So to correct their problem with the overcapacity in their department. So they started to have something more extreme, which is hypofractionation breast cancer of 1 week versus the 3 weeks. So the 3 weeks now started to be standard now, and now they are comparing much extreme hypofractionation. So they opened the fast forward trial, which is this is the inclusion criteria. It's similar to the START A and B. And this is the randomization. They randomized the control group, now it's 40 to 26 and 5 and 27 and 5. And if you look to the number in between the bracket, it is equal. So between November in 2011 and June in 2014, they started to randomize, which is after the 10 years follow-up from the START B. And they, in their study, they were looking for non-inferiority in the result, number one, and good side effect. We don't have toxicity, because when you look to 26 and 5, the first thing will hit in your brain is this will be toxic in the patient. So this is the primary endpoint, ipsilateral local control, and the secondary endpoint, many things, but the major thing is the side effect. In this study, they were very constrict about the constraints. So in the control group, they were looking to the lungs, 12 gray should not receive more than 15%, and in the heart, the 2 gray and 10 gray should not exceed 30% and 5%. And in the test group, also 8 gray should not exceed 15%, and the heart, 1.5 and 7 gray should not exceed 30 to 5%. And this is the result. Quickly, I'm not going to spend all the time here. If you look to comparison between the 40 and 27 and 26, we found that the tumor control in the 40 gray was 2.3%, to 2% in the 27, and 1.5 in the 26. And we found that the local relapse approximate equal. The death from the 40 gray and the 27 and the 26 was from breast cancer. Second cancer also was equal. We don't have another reason of cause of death other than breast cancer. If you look at the cardiac, it's 0.7 in the 40 gray and equal in the both gray. But here, we find that they're different in the toxicity, because as we mentioned in the beginning, the aim of the study is look to the control and the toxicity. So the toxicity here, looking to any adverse effect of the breast and chest wall, was different really and significantly different between the 40 and the 26 and the 27. So we find worse result in the 27 gray and 5 fraction. Look into the breast distortion, also we found that it's more with the 27. It's still more than in 26 comparing to the 40, but still it's not significantly different. Breast shrinking was more in the 27, breast induration more in the 27, and even the telangiectasia and the breast or chest wall and edema was all worse in the 26. That's why 26 and 5 was out of the protocol, and the final comparison was between the 40 and the 26, and the 10 years follow-up were going to be between these two regimens. The fourth strategy that we are experiencing in our country and in my institute is to activate the partial breast radiation, especially in an early breast cancer, such like T1, young age, less than 50, less than 2 centimeter, good biological feature. We activate the partial breast radiation. In our institute, we use intraoperatives to use that, but even in institute, not having intraoperative, there is another way to give this partial breast radiation. It can be given by multi-catheter brachytherapy. It can be given by mammocyte balloon, and it can be given by intrabeam, which is found in the 2 institutes here in the country, and by Mimetron, and we can give it also by external beam radiation therapy. So even if you don't have all these modality in your department, you can activate that to reduce the time of the treatment and preserve patient couring to the hospital and increase the risk to having transmission of the disease. So there is a couple of multiple studies showing the benefit of giving partial breast radiation in early breast cancer. Different regimen. We have the Spain regimen where they give 48 and 24 plus or minus boost, comparing to 37 and 10 over 2 weeks, and show no different. The UK gave the same dose, which is the 14-15 as a whole breast and 14-15 as a partial breast, just to the tumor bed, and shows no benefit. And also the Italian, which is very short, comparing 15-25 plus or minus boost to 30-5, and show no toxicity, but little bit increase of the local recurrence. So this is a little bit doubtful, but we can think about the other regimen, which is 38.5. So what's in the future? Can we reduce more the fractionation? Can we open the door for stereotactic radiation to the breast? Yes, always the door is open. After looking to the radiobiology of the breast cancer, we found that this tissue, the breast tissue, can tolerate hypofractionation. There is a small study here, one arm. Interesting. I thought I just mention it here for future study and something we can think about it and look about in the future, which is a stereotactic image-guided neoadjuvant ablative single-dose radiation after lumpectomy, early breast cancer, less than 3 centimeter, good features, estrogen positive, clinically negative lymph node, and it should be at least 2 centimeters from the skin. The patient is treated in prone by using MRI, and they give 21 gray neoadjuvant fraction by external beam. They use here CyberNav. You can use even VMAT and perform the surgery a week after. The result is it's a very mature study. They're gonna make more randomized multi-study to think about it, but they found, at least in the beginning, after 6 months, that the toxicity is tolerable and the cosmosis is good. So I think it's an interesting study. Why is interested? Because you're treating neoadjuvantly. The most difficult things I face treating partial breast radiation adjuvantly is the distortion of the surgical bed, and not all surgeons in the country doing or inserting clips. So always you find the problem geographically, but here you will solve this problem. Thank you so much. Still, the pandemic is not over. I wish it's close to be over. So live safe, social distance, use your mask and wash your hand, but still keep the hyperfractionation treating your breast cancer. Thank you.
Thank you very much, Dr. Riyad Saeed. My first question, if the patient have tissue expander after surgery, after mastectomy or skin sparing mastectomy, do you recommend the fast forward or not? And if you don't recommend the fast forward, what about the 15 fractions? Is it acceptable or not?
Very nice question. And the nice about this question that I had a patient last week with tissue expander.
I cannot hear your voice. Yeah.
Can you hear me now?
Yes, yes.
The beauty about this question, Adnan, is I had a patient last week with a tissue expander coming to my clinic. Really, in the study, they're mentioning it was included. But my experience, tissue expander and the plastic surgeon, they think that radiation can affect that. They excluded, American exclude all the hypofractionation after immediate reconstruction. But still, I used it in the 15 fraction, 14-15, with good result, good benefit, and it's there in the study. The fast forward, I'm going to take it easy. Really, in the fast forward, I'm not using that, the fast forward, except in treating breast, early breast, without lymph node. With tissue expander, with other conditions, I'm going to wait. I'm going to take it easy, Adnan. I'm going to wait for the 10 years follow-up, more details. I'm not going to rush it. For answering your question, no, I will not use the fast forward. I'm going to go, but I will give the 15 fraction.
Thank you very much. While they are preparing for Dr. Sahibani, just one question for Dr. Mushabbab Asiri. Which worse, SARS or COVID-19? Dr. Mushabbab, are you with us?
Yes, I am. SARS is the name of the virus. COVID-19 is the name of the disease. So I think the one who asked the question can answer himself.
Yeah, which dangerous, he said.
This is the same. SARS is the virus itself. But
Okay.
when the virus caused symptom and disease, it became COVID-19.
Okay.
They are the same.
I believe
SARS is the name of the virus, not the disease.
He believed, I believe he mean the old SARS during 2003.
You mean SARS-1?
Yes.
Yeah.
No, SARS-1 is far worse than SARS-2. The fatality is very high. I don't remember the figure exactly, but I think in the range of 7% maybe.
Okay. Dr. Nasser Adibani, would you like please to present our nice colleague?
Sure.
Dr. Adibani?
Thanks.
Or you want me to go ahead?
No, I'll give you a break for just 1 minute because I think you work very hard with us. Thanks, Dr.
No problem.
I'd like to introduce Dr. Abdullah Sahibani. He's our senior and our colleague at King Saud. He's the head of radiation oncology department there. He will talk today about the GI hypofractionation in rectal and other cancers as a solution for COVID-19 outbreak. Go ahead, Abdullah, please.
Okay, well, thank you, Mr. Chairman, for this nice introduction. And thank you for the organizing committee for having me for this excellent conference. And it's been an honor to be among our distinguished speaker. So, COVID-19 outbreak and GIT cancer, hypofractionated radiation therapy. That's the task I'm being given to go over. So, I'm not having the control of my slide. Okay, now. So I'm not going to talk about the corona and how this started, but in GI, I think we usually at the beginning of the pipeline for the treatment or at the end. Your starting of the treatment will affect all of the other discipline, surgery and chemotherapy afterward in most of our cases. So when the COVID-19 started, all the health system has been taken in shock. And at the beginning, it was individual kind of decision for each of the department to make their own recommendation about the hypofractionation and choosing from available evidence to go over. And then not so long, we have the international response. So many communication and recommendations from different international organization. So the one I'm sharing is the COVID-19 rapid communication. It was published in the Green Journal. And it just gives a general guidelines of what's acceptable to be used. And it's a range of fractionation. In GI, we used to believe that 1.8 gray to 2 gray is the conventional, and more than that will definitely have significant impact on long-term toxicity. And this nice report, it proved that based on some evidence not previously been popular, maybe 2.5 gray is still okay. So in esophageal cancer, we already have our cross trial, and we have another option of 40 gray 15. They have it as part of the new adjuvant treatment. In gastric, I think you will have to decide about whether you treat or not. We already have other alternative adjuvant treatment apart from radiation therapy. Many of our colleagues, they already not offering it as a part of their standard, but it's all, they show the same effect. For the liver and cholangio and pancreas, they are pushing more and more toward extreme hypofractionation / SPRT. For rectal cancer, we already have this long debate. We will allude to it in a minute about whether going for conventional fractionation or shorter fractionation. And for the anal canal, I think the recommendation still stands for the conventional fractionation. And part of their response was to go deeper in terms of recommendation of treatment or not for early disease in rectal cancer. And probably this is part of the ISMO guidelines recommendation of how they approach the early disease and rectal cancer. And they have the excellent TME surgery, for which they have a long standing history of low recurrence rate. For that, they have a very detailed evidence based on some of these factors, either in the imaging or afterward in pathology, where they could omit radiation therapy for the early rectal cancer. For the intermediate and local advanced, for them, still short course is acceptable. And for aggressive or ugly disease, as per the ISMO guidelines, they still need a more aggressive approach in terms of chemotherapy or adding chemotherapy as a part of the neoadjuvant treatment. So we focus more on the rectal cancer. So before the pandemic, and that's probably the two landmark study that shape our treatment recommendation, the Dutch group and the Swedish at the same time for the short course fractionation, and then the German trial for the neoadjuvant chemoradiation, just two slides for each. So the Dutch group randomized between TME surgery alone versus pre-op, followed by the TME surgery of a short course. And 2 years, it shows significantly improved local control for pre-op short course radiation therapy. And even at 5 years, this result stands. And for the German trials comparing the pre-op versus post-op chemoradiation therapy, and it showed significantly the local control significantly improved on the, if you give the patient pre-operative chemoradiation. Not only that, acute toxicity and sphincter sparing and better compliance for those who received the pre-op radiation. So this is where we stand before the pandemic started. And at that time, most of us were debating whether pre-op short course or long course, where we should have the practice. And that's the debate that we usually have. And we already have probably 2 studies randomizing between the 2 groups, whether giving short course radiation therapy alone or fractionated chemoradiation therapy, the long course. This paper by Kujiku, and they had 300 patients randomized to receive either approaches. And the eligible patient, clinical T3, clinical T4, but patient has to have a 3 movable tumor. So probably most of the T4 will be excluded in this trial. And it's have to be not completely involving the circumference of the rectal wall. Local control was not statistically significant between the 2 groups. Same as for oral survival and disease-free survival. And the other Australian study comparing the clinical T4, only clinical T3 patient, randomized between the pre-op short course radiation therapy versus long course chemoradiation therapy. And here we have the patient characteristic, and it was balanced between the 2 groups for patient related and tumor related. And it's mainly T3 disease. And the result, it showed the recurrence-free survival as well as a overall survival were similar in between the 2 groups. The same goes for cumulative incidence of recurrence. And it was 3 years local recurrence between short course and long course were not statistically significant between the 2 groups. And it was recommended a longer follow-up to better evaluate the outcome of for these 2 studies. Short course, especially during the pandemic, was very favorable, not just only patient convenience. If we recall that some of the patients will have exposure to other patients who has a COVID, and those patients will be interrupted for a few days till they are being screened and the result. So reducing the time the patient will come to the hospital increase the chance of the patient will complete his course of treatment therapy. So more than just, access to the service itself. And the main disadvantage for the short course at that time was that the surgeon don't like that much because you will push them to do the surgery within a certain time. Although evidence we have that delayed surgery is still okay and safe, but some they have a bad experience, so they are not very favorable of that approach. And we are waiting for even further study to assure us of the safety of that approach. The long course were most popular in our area for multiple reasons. It's a safe, we have a good experience with it, and the surgeon will have a longer time to plan their surgery. And we have a very favorable result, especially the BCR rate. For BCR rate, many reports showed that if the patient achieves a complete response, they have a very favorable oncological outcome. And here, one of the systemic review, it showed distant metastasis for patients who had the PCR was very superior as compared to who did not achieve. The same goes for overall survival and disease-free survival. So it's some endpoint that everybody is trying to get to their patient to achieve PCR for this oncological outcome. But again, back to these two trials that comparing short and versus long, it showed the initial comparison, it showed equally effective, both approaches with no significant superiority of either of them. At that time, the recommendations, as initially seen in the first slides, this is probably part of the ESMO guidelines. They have divided the rectal cancer in a different way than what we used to say, very early, intermediate, and then they have badly and ugly disease. And although they recommend short course for most of these, but for the advanced disease, they recommend treatment intensification with either longer course of chemoradiation therapy or delayed surgery. So at that time, many of the centers they try to adopt some form of total neoadjuvant therapy, and even based on small studies that was published and then followed by the Prodigy study that's been taken to the guidelines, especially for a patient with very advanced disease with either positive CRM or T4 or multiple lymph node. In both the NCCN, the American as well as the European guidelines. And we were eagerly waiting for the Rabido study that was started some time ago before 2015. And we were anticipating the result. And the result came in actually in no better time than when it was initially presented in ASCO of 2020, and soon after was has the full publication. So the Rabido was trying to evaluate total neoadjuvant therapy followed by following in short course radiation therapy. So short course followed by chemotherapy before the surgery in a locally advanced rectal cancer. So they have 54 centers recruiting patients. And it was open label phase 3 randomized control trial. At that time, based on all of these previous evidence, local recurrence since the TME has not been the major issue in the management of rectal cancer. So most of the reported local recurrence is below 5%, but most of the failure happen mainly in a distant area, liver and lung, after the patient completed their treatment. So going back to the adjuvant chemotherapy was given either post the short course or post the chemoradiation therapy, the effect and the compliance was not that great. So that's probably one of the very things that we would like to address in the total neoadjuvant therapy, since this approach has been successful in other sites of cancer, in breast and others. So we would like to test it on rectal cancer. That's one of the studies that trying to address this. So the disease-free survival in the locally advanced rectal cancer was less than 75% due to distant metastasis. The aim of the study was to reduce the distant metastasis without increasing the local failure in a high-risk locally advanced rectal cancer. The effect of adjuvant chemotherapy is not proven because all of this study was done, it showed very low compliance rate. 5x5 followed by long interval, it's done in some of the studies and showed improvement in the downstaging. So in the longer interval between the surgery and radiation, it showed clearly, even in the long course, clear downstaging. And some of the oncologists are concerned about this window and the patient is not getting any treatment. So this trial is answering that and giving the chemotherapy that patient used to have as adjuvant, bring it all the way to the front before the surgery. So during that time, patient will receive a neoadjuvant chemotherapy. So the study design was a standard arm that was labeled as the 5.5, 50.4, and 28, although 53 and 25 was allowed. And then 8 to 10 weeks interval surgery, and then adjuvant chemotherapy based on institutional recommendation. The experimental arm start radiation therapy with a 5x5 within maximum radiation have to be finished within 8 days. So prefer to start Sunday, but you're allowed to start sometimes, provided that you finish within 8 days. And then within 18 days from the end of radiation therapy, you start your neoadjuvant chemotherapy. And the protocol called for 6 cycles of K-Box or 9 cycles of Folfox. And then 2 to 4 weeks later, patient will go for surgery. Main inclusion criteria was for very advanced disease. So for either T4A to T4B, patient has to have at least one of these features. The EMVI into or positive CRM or a large lateral lymph node. The primary endpoint was disease-related treatment failure, defined in either distant mets or local regional failure or new primary colorectal cancer, or even treatment-related death. The secondary endpoints overall survival, R0 rate, PCR rate, toxicity, surgical complications, and quality of life at 3 years. And the hypothesis was improvement in disease-related treatment failure at 3 years from 30 to 22.5 with 80% power. Will require 842 evaluable patients and 280 event needed. So these centers that they participated in this study, mainly in Europe, and they have one center in US as well. So that's randomization, as discussed earlier. The patient will go from the experimental arm for the radiation, followed by the neoadjuvant treatment and then surgery. And they, for patients who go for the standard arm, only 187 patients received the adjuvant chemotherapy because it was left to the institutional discussion. So the baseline characteristic was well balanced between the two groups in terms of the patient-related as well as the treatment-related and center-related as well. So this is the patient, the tumor-related risk criteria. Again, it was well balanced between the two groups, and number of risk factors as well was being addressed and balanced between the two groups. So yeah, just to be sure that we have a very homogeneous distribution. So the toxicity of the treatment, more than grade 3 or more, was mainly neurological, but this was more in favor of the experimental arm as compared to those who received adjuvant chemotherapy in the standard arm. And diarrhea was very common in both group and more in the experimental arm. So surgery with a curative intent, less than 6 months after the end of neoadjuvant treatment. The type of surgery as well balanced between in terms of anterior section, low anterior section, or IBR or Hartmann between the two groups. Surgical complication was detailed and presented. Wound complication, bleeding, intra-abdominal infection was not statistically significant between the two groups, as well as the anatomical leak. As for pathology of the resected rectal tumor, the R0 resection was not statistically significant between the two groups. But however, the PCR rate was doubled in the experimental arm as compared to the standard arm. So for the PCR, pathological complete response was 28% on the experimental arm as compared to 14% on the standard arm. Disease-related treatment failure, it showed significant improvement for the experimental arm, as well as for distant metastasis. It was very superior in the experimental arm, and local regional failure, it was not statistically significant between the two groups, although it's tending toward improvement on the standard arm. The baseline characteristic of patient who received adjuvant chemotherapy from the standard arm, disease-related treatment failure, I mean, it showed significant improvement for those who received the treatment. Survival was the same between the two groups, and quality of life as well. It was one of the issues that we usually discuss and present when we talk about the short course radiation therapy. It was very detailed in this application or this presentation as well. And they go for all the detail, and it showed it was not statistically significant between the two groups, either those who received neoadjuvant radiation, only short course followed by chemotherapy and then surgery, as compared to the concurrent chemoradiation therapy followed by the surgery. So the take-home message from the RAVIDO, there was significant lower disease-related treatment failure, 7% from 30 to 23. The same goes for distant metastasis, 26 to 20, and doubled the PCR rate from 14 to 28. And overall survival was the same in both groups. There was no unexpected toxicity and no difference in surgery or post-operative complication and quality of life. So in conclusion, the neoadjuvant therapy, rectal cancer should not be considered as a one-size-fits-all approach. Short course and chemoradiation therapy, long course, are equally effective in regard to local control in selected T3 patient. However, for locally advanced or aggressive or ugly disease, they require more treatment intensification. And the one we presented at the RAVIDO approach with the neoadjuvant chemotherapy followed by short course of radiation therapy. And other approaches like the Grodige trials were neoadjuvant chemotherapy followed, neoadjuvant radiation therapy long course followed by neoadjuvant chemotherapy and then surgery. Thank you.
Thank you very much, Dr. Abdullah Sahibani, for this excellent presentation. I have quick two questions. There is no specific questions. For Abdullah, for the lymph node coverage in short course, do you do the same coverage as the long, or you are more conservative? And the second one is, what kind of constraint? Do you follow the trial constraint, or you have your own institutional constraints for organ at risk?
Okay, thank you. It's an excellent point. So for the volume coverage of the CTV, they're the same for both the group. As for the constraint, I think there's many, published constraint, but mainly they used BED calculation to achieve their constraint from the standard fractionation regime. So this trial has a broad kind of constraint since it started much earlier in the time. But we used more strict recommendation as we are adapting VMAT in all of our treatment.
Well, thank you. Before Dr. Adnan introduced Dr. Amin Al-Umair, I'd just like to update you about a chat update by Dr. Mushabbab, who mentioned a facts about SARS-1. Although it only affects 8,000 in 29 countries at that time in early 2000, but it is less it is less infectious, but it's very fatal. The fatality rate at that time is 10% compared to 2% in COVID-19 SARS-2. But as we know that SARS-2 COVID-19 is more infectious and less fatal. This is an update. And Dr. Adnan, please go ahead and introduce our last speaker, Dr. Amin Al-Umair.
Thank you very much, Dr. Ribani. Really, I am enjoying the presentations from Dr. Huwej Mukhlas. He mentioned CHIP trial in prostate, then the fast forward from Iyad Al-Saeed and Rapido from Abdullah Al-Sahibani. Thank you very much. And now for the thank you for the organizing committee. They selected the cancer according to the prevalence, the incidence in Saudi Arabia. So they started with the breast cancer and then colorectal malignancies, and now with the lung cancer with Dr. Amin Al-Umair. Amin Al-Umair, he's a consultant radiation oncology at King Faisal Specialist Hospital. He did his training at University of Toronto. He did subspecialty in spinal stereotactic radiosurgery and head and neck radiation surgery. And surprisingly, he was now currently the expert in lung cancer in Saudi Arabia. He's doing the busiest service in lung cancer at King Faisal Specialist Hospital. And now he's expert in SBRT, stereotactic body radiation therapy in lung cancer. It's really my pleasure to present Dr. Amin Al-Umair, and we are willing to hear from you. Something changed our practice, like in Rapido and the CHIP trial, as well as the fast forward. Please, Dr. Amin Al-Umair.
Thank you very much, Dr. Adnan, and thanks to the organizing scientific committee, in particular, Dr. Maha Idrisi, Dr. Nasser, Dr. Maghribi, for the opportunity to talk to you today about the COVID-19 outbreak and lung cancer hypofractionated radiation therapy. So I'll start off, this is the outline for my presentation. I'll start off with one of the most successful story of hypofractionation and radiation therapy. Particularly in early stage non-small cell lung cancer, which was started way before the COVID-19 outbreak. So most of you know that the standard of care for early stage non-small cell lung cancer is to treat patients with surgery associated with high chance of cure rate. But how about if the patient is not fit for surgery or inoperable or refusing surgical treatment? Then if we go back to 70s and 80s, back then, the only alternative is radical radiation therapy, and the conventional fractionation, the outcome is not great. To improve this outcome, the story of hypofractionated started, as I mentioned, maybe 30 years ago. So one of the institutes in Canada, Kingston, I'm reviewing the published experience by Dr. Patrick Chung for patient who has early stage non-small cell lung cancer and inoperable. Try to improve the outcome or intensify the radiation treatment. They use a hypofractionated treatment. They use a common Canadian fractionation, 50 gray and 20 fraction. And I show you this curve This is the Kaplan-Meier curve for survival showing us the result. It's very poor, which is very disappointingly. The 5 years of survival is very low. You always can argue that this patient end up with radiation because of the comorbidity, and likely they died from other comorbidity, but this is not true, because if you look at the cause-specific survival curve, you find two things. First of all, the 5 years cause-specific survival is very low. The other thing is the curve is plateau, suggesting that most patients died from cancer, lung cancer, and nothing else. The next logical step when we have poor survival is to do dose escalation. So instead of using 2.6 gray per fraction, why don't we use 4 gray per fraction? And this is what has been done in Sunnybrook in Toronto for years and years back in the 90s, where Dr. Solomon reviewed the 10 years experience of accelerated hypofractionated radiation therapy for early-stage non-small cell lung cancer by using a fraction size of 4 gray, ranging from 48 up to 60 gray in 15 fraction. And you can see that the result compared to the historic outcome improved significantly, and the curve plateau, indicating that we achieved a better local control as well as overall survival and cause-specific survival when we escalated the dose of radiation. This trial was led to a multi-center NCIC Canadian trial, which is a phase 2 study of hypofractionated radiation therapy for inoperable early-stage non-small cell lung cancer. The standard of care here to use 60 gray and 15 fraction. Again, the result has improved. We're comparing this result with historic outcome, and so far we're doing good when we moved from a little bit of hypofractionation to higher dose, but the logical things, if a little bit of hypofractionation is good, so 4 gray per fraction is good, then extreme hypofractionation might be better. And this is the era of SBRT, where we instead of 60 gray in 15 fraction, we give 60 gray in 3 fraction or in 5 fraction. So the SBRT actually aborted the era of mild hypofractionation in lung cancer, but the outcome has significantly improved with SBRT, as all of you know, and the toxicity is very acceptable. And for this reason, we start even comparing SBRT head-to-head with surgery for patients who had early stage non-small cell lung cancer. Most of you know that those randomized control trial, its old one was aborted early because of low accrual. But what's important things to me is the fact that most of us, and most of the randomized trial, most of the trial, they are using 60 gray in 3 fraction. They use anywhere between 3 to 5 fraction. So let's move now to the era of pandemic. And the most practical question is, can we use less number of fraction? Why don't we use single fraction lung SBRT as opposed to 3 to 5 or sometimes even 3 to 8 fraction? And this question actually was addressed almost 12 years ago by the NRG, the old RTOG 0915 trial, which is a randomized phase 2 study comparing 2 SBRT scheduled for medically inoperable stage 1 non-small cell lung cancer. I'm talking about peripheral located lesion. And so as I mentioned, one arm receiving single fraction 34 gray, and the other arm received the common Japanese fractionation 48 gray and 4 fraction. And there's no difference in the oncological outcome, not the overall survival, not the progression-free survival, and also the toxicity in both arms was comparable, making a point of in favoring of using single fraction for a resource, for the pandemic, and for any other, for cost, and for any other reason. This also was confirmed by a more of retrospective trial as opposed to the previous randomized trial. This is a very large institute experience in Roswell Park, comparing single fraction versus 3 fraction. And the median dose for the single fraction is 30 gray single fraction, and the median dose for 3 fraction is 60 gray and 3 fraction. We're talking about peripheral lung lesion and early stage non-small cell lung cancer, and the overall survival curve is overlapping, indicating that both arms are equivalent in terms of overall survival. So we have this retrospective trial, but also we have a randomized phase 2 trial. And the I'll move from the one of extreme of staging, which is the most early stage lung cancer, to the stage 4 non-small cell lung cancer. So from one extreme to other extreme, But here we're talking about oligometastasis. So we know that sometimes if a patient had single lung mets from, say, non-small cell lung cancer primary, the question is, can we extrapolate the data from the previous RTOJ trial and the Roswell Park trial of using single fraction? And I guess the answer is yes, because it's feasible, it's safe to do so. But do we have particular evidence specific to a patient with oligometastasis? And the answer is yes. This is the Australian, the TROG trial that was presented last year and Astro, comparing for patients with oligometastasis. And here we are talking about lung SBRT for lung oligometastasis. By and large, most of the lung metastases came from non-small cell lung cancer primary, but the trial includes all the primary solid tumor. One arm is getting 28 gray single fraction, and the other arm is getting 48 gray and 4 fraction. The primary endpoint was the toxicity, and the study met the primary endpoint, where actually there is no statistical significant difference in terms of toxicity between the two arms, the single fraction and the 4 fraction. Not the other oncological outcome. Local control is similar, progression-free survival and overall survival is similar between the two arms, indicating that you can use single fraction lung SBRT even in oligometastasis lung primary. So these findings may have implication for treatment selection in resource-constrained environments, such as the global pandemic or the bundle payment environment. So we'll move now, as we have talked about the extreme of stage, the early one and the most advanced one. So let's talk about the bread and butter of daily radiation oncology practice. Large volume of our lung cancer have locally advanced non-small cell lung cancer, i.e. stage 3 non-small cell lung cancer. And here the story is different. We are not, most of us, not comfortable in using hypofractionation plus chemotherapy. So the standard of care to use anywhere between 60 to 66 gray and 2 gray per fraction, over the period of 6 or 6.5 weeks. We're not comfortable in hypofractionate plus chemotherapy, but this is not true for colleague in the UK. They always routinely, before the pandemic, they use a very common UK fractionation, 55 gray and 20 fraction, along with concurrent or sequential chemotherapy. And this is the trial that was published in the Green Journal, pooled analysis of from 4 major UK centers, publishing their experience of 55 gray and 20 fraction, a course of accelerated hypofractionated radiotherapy course. And they treated almost more than 600 patients in this retrospective trial. And they actually showed a very impressive 2 years overall survival, 50%, very comparable with the historic outcome. However, the limitation of this trial, not only retrospective, it's actually half of patients had stage 1, and we're talking about locally advanced non-small cell lung cancer, and minority of patients receiving chemotherapy. And to avoid this 2 major criticism, I actually managed to review another publication from UK, only 100 patients, exactly similar dose, 55 gray and 20 fraction, exactly similar 2 years overall survival like the previous trial, but they actually, all of the patients here are stage 3 non-small cell lung cancer, plus they use chemotherapy as well. But the criticism of this trial is retrospective, so maybe still our level, our comfort level is not increasing to change our practice even during the pandemic. But we do have the SOCAR, it's a randomized phase 2 trial comparing sequential versus concurrent chemotherapy and radical hypofractionated radiotherapy in a patient with inoperable stage 3 non-small cell lung cancer and good performance status. And this trial, interestingly, exactly similar outcome in terms of 2 years overall survival of 50%. There is no major difference between sequential and concurrent chemotherapy when you hypofractionate. And the conclusion from this trial is hypofractionated radiotherapy with chemotherapy is feasible and reasonably safe for patients with stage 3 non-small cell lung cancer. I warn you, I will use this only during the peak of the outbreak, but not changing the standard of care, because we never had a head-to-head comparison with the standard of care. So yes, the answer is yes, we can hypofractionate even for stage 3 non-small cell lung cancer with chemotherapy during the peak of the pandemic. So let me move from non-small cell lung cancer to small cell lung cancer, but also I will move from hypofractionation to complete omission of radiation therapy during the pandemic. And for limited stage, we have nothing to change, but for extensive stage small cell lung cancer, we have two indications for radiation. One is PCI, and PCI is the standard of care. It improved the overall survival at 1 year by more than 10% in Europe, but not in Japan. So why do we have conflicting data? I'll walk you through it. So let's see why do we have this controversial issue. So PCI and extensive stage small cell lung cancer has shown to be improved overall survival compared to the patient who went into the observation arm. The major criticism of the European trial or ERTC trial is the fact that they had baseline imaging, and for patients who had no brain metastasis, they started the standard of care, 4 to 6 cycles of induction chemotherapy. After induction chemotherapy, they should do restaging with brain imaging. They have not done this. So probably they include patients who had brain metastasis in this trial. This is a major criticism of this trial. It's a positive trial, as I mentioned, but to avoid this criticism, the Japanese did it slightly different. So the Japanese, for extensive stage small cell lung cancer, who completed the induction chemotherapy, immediately they do MRI brain. If patient had no brain metastasis, then he will be randomized, one arm getting PCI and the other arm getting observation with interval MRI follow-up. They call it MRI surveillance. And it's a negative trial. There is no difference in overall survival. So now, to confirm this finding, before talking about SWAG trial, the bottom line from ERTC and Japanese trial is that PCI did not result in longer overall survival in the Japanese trial compared with the observation. And PCI is not essential for extensive stage small cell lung cancer without brain metastasis when patients receive MRI surveillance. To confirm the Japanese trial, now there is ongoing SWAG phase 3 randomized trial of MRI surveillance or observation in one arm versus PCI in the other arm. At King Faisal Specialist Hospital, I'm lucky to be part of this trial along with Dr. Hamd Al-Husseini. We are accruing patients in this trial to address this important question. So let's move to the other part of extensive stage small cell lung cancer. So we know that this trial creates a lot of controversial, where some experts believe that you should give thoracic radiotherapy after induction chemotherapy for extensive stage, and others, they don't believe on it. Why is that? Because the primary endpoint of this trial, European trial, which randomized a patient with extensive stage small cell lung cancer after completion of 4 to 6 chemotherapy cycle into one arm, getting thoracic radiotherapy, 30 gray Entien fraction, and in the other arm is the standard of care, which was no radiation therapy or no thoracic radiotherapy. They go directly to PCI. And the primary endpoint was the overall survival at 1 year. And the primary endpoint is negative because there is no statistical significant difference between the two arms at 1 year. Interestingly, they noticed that at 2 years, there is the curve separated significantly, almost 10 years overall survival in favor of the thoracic radiotherapy. So some authors think that the trial did not meet the primary endpoint. It's a negative trial, so they don't routinely offer thoracic radiotherapy. Others, they go with the 2 years overall survival advantage. And because of this issue, you can safely omit radiation therapy. It's not, the indication here is not strong. I would say it's soft indication. Let's summarize my recommendation during the peak of outbreak. So you can use single fraction radiosurgery anywhere between 28 to 34 gray for early stage non-small cell lung cancer, because it's comparable to 3 to 5 fraction. You can use it for early stage. You can use it for lung oligometastasis if there is strong indication to treat. For stage 3 or locally advanced, you can use 55 gray and 20 fraction concurrently with chemotherapy. And you can omit BCI and thoracic radiotherapy in case of extensive stage small cell lung cancer. This was my last slide, and thank you very much for your attention.
Thank you very much, Amin, for this excellent summary and updating in the management of non-small cell lung cancer as well as small cell lung cancer. I have one question. What about the PCI in limited stage small cell lung cancer? Do you still recommend the PCI, or it will follow the same?
Outside the outbreak, or?
No, yeah, no, as a practice for small cell lung cancer.
Well, yeah, I do recommend PCI for limited stage based on, because there is no conflicting data.
Yes.
I know it's driven by meta-analysis, not by individual trial. But also, Adnan, I do recommend it for extensive stage now, off trial. So on trial, we are part of the spike. But off trial, I will do it for a variety of reasons. I know the limitation of the EuroTC trial, but always Japanese argue that they do have different population in terms of genetic background and driver mutations. So, and this is why the SWAG repeat the Japanese trial. So still had discussion with the patient about both. I always do it with hippocampal sparing, PCI, and sometimes I try to use memantine, but not even for excessive stage. I still do it, or I have discussion with the patient about the conflicting data, and let's him choose the treatment.
Yeah, it is not only survival. Actually, the prophylactic radiation will decrease the incidence of brain metastasis by 50%, which is really morbidity for patients with to present with brain metastasis.
I agree.
Thank you very much for the for your lecture, and the microphone go back to Dr. Dibani.
Thanks a lot, Dr. Adnan, and all the speakers. Excellent. And before I hand over to Dr. Maha and Dr. Maghrabi, I'd like on your behalf to thank them for this excellent conference behind the scene. Dr. Maha, Dr. Maghrabi, Mr. Ghayur, Mr. Brian, and all the organizing teams. Go ahead, Dr. Maha and Dr. Maghrabi.
Yes, I would like really to give my sincere thank to all the speaker, moderator, and special thank to our Executive Director of the Oncology Center, Dr. Khaloufa, our team partner, Dr. Sharif Samman from Medical Oncology, Dr. Hafiz from Palliative Care. They all had helped us to reach our goal to share this information about radiation services during the COVID and how we can manage our patients. Special thank to the Saudi Society of Internal Medicine for their generosity and helping us to carry this great conference that actually not only was focusing on radiation alone, but actually was covering the also medical oncology and palliative care. And great special thank also to the event troop company for helping us organizing this activity. And special thank to our chief radiation therapist, Mr. Ghayur, and our quality coordinator therapist, Mr. Brian. They are actually the hidden soldier who are helping us to carry this conference, and I appreciate all the effort from everybody who helped us, and we look forward to see you in our coming conferences. And once more, would like to give my sincere thanks to everybody who are helping us to achieve our goal. Thank you all.
Thank you. Yeah, actually, just one comment here that brings us to end of our sessions. Thanks so much for the speaker and moderators. And inshallah, we keep up with the conference in yearly basis. Inshallah, we promise you, inshallah, with this outstanding success of this meeting. Actually, inshallah, me and Dr. Maha and Dr. Nasser and all the organizing committee, inshallah, will try to arrange it in yearly basis, and then we'll have like an outstanding, inshallah, meeting physically in your presence, inshallah, we'll do it with overcome this tough period, inshallah, see you again, inshallah. Thank you.
Thank you very much, all of you.
log off now. I will continue with the event group company.
بارك الله في جهودكم، استودعكم الله سبحانه وتعالى.
أما الله، شكرا لكم جميعا زملاء
كان
وزميلات.
جدا رائع والله، اشكركم جدا والله.
شكر
والسعوديه ممتاز.
ألف شكر لكم يا دكاترة وجهودكم جميعا، ألف شكر والله.
بارك الله في جهودكم جميعا. السلام عليكم ورحمة الله وبركاته.
مع السلامة.